Oh, I'm sorry.
We're relying on each other more and more just to keep the system functioning. And we've had to shift our mindset a little bit away from what are all these kind of long-term goals that we were working on and laying the foundation for, to say, okay, we might need to pause a little bit of that because the foundation's crumbling underneath us. So times are really difficult. They're difficult for Pennsylvanians. They're difficult for people who work in our field. They're certainly difficult for folks working in our office. So, you know, I just ask that there be sort of a continued extension of grace to each other during this time. And as I tell my staff pretty often, assume positive intent as much as you can.
Oh,
you know, we're all
yes, I do.
really stressed, really overburdened. And when you're in that mental state, it becomes really easy to get defensive about things, to get frustrated. And so really just try to assume that the folks that we're interacting with have positive intentions just as we do. And we may have some differences of opinion about how we accomplish some of our goals. But if we're assuming that everyone's intent is pure and good, it gets us to a more level. So before we kind of dig into giving you an update on some things going on within our office, I thought it might be helpful. I have met some of you before, others of you I know by name, but not necessarily had a chance to converse with. So we're going to start things off with just giving you a little bit of background about ourselves. So I'll tell you a little bit about me, and then I'm going to pass the mic to Julie, and she's going to tell you a little bit about herself. And I think it'll become really clear if you haven't met her previously, why she was selected to serve in this role. And then we'll kind of dig into some of the what's going on in the world kind of things. So by way of background, I am a career state government employee. That means my entire professional career, about 22 years, has been in Pennsylvania state government. By education and training, I am an accountant, believe it or not. So I graduated from Shippensburg University in South Central Pennsylvania and started working for the state the week after my graduation as an accountant in the Office of Budget, and did that work for several years and remained in the Office of the Budget, but moved up into some different kinds of strategic roles where I was doing strategic planning and developing communication strategies and managing basically all things that weren't numbers. So I was doing the HR pieces and facility management and that kind of thing. So in total, I was with the Office of the Budget for about 10 years. And then an opportunity presented itself through someone that I had met, many years before, called me out of the blue and said, hey, there's going to be an opening at the Department of Drug and Alcohol Programs as the Deputy Secretary. And I really think you should apply for that. I said, crazy. I don't know anything other than knowing that that department exists. I don't know anything about that work. That's not my training. That's not my field of study. I don't know. She said, oh, it'll be really good for you. I think it would be a good fit. Just promise me that you'll give it a go. So I sent my resume in. They scheduled an interview for me. I left the house that morning not wearing my power suit. And saying to my husband, like, well, this will be good experience for me. I haven't been on an interview in a while. This is good for me to get back on that bicycle. Went into the interview, an hour later, walked out, called my husband and said, I really want this job. And he said, well, what changed in 60 minutes? And I'll tell you what changed in 60 minutes was a realization that something that I had felt was missing in my life from a religious perspective for many years, which was a desire to do missions work, didn't need to involve leaving the country and leaving my family behind to do missions work. That missions work could mean doing that work right here, right here in our communities, right here in state government. And the secretary at that time, Gary Tennis, of course, is a very compelling man, former district attorney, so he knows how to convince people. And I just felt like this was the right move for me, despite the fact that I really had no training or experience to offer. When I took the job, he promised me that he wasn't giving me the job because of my clinical knowledge or expertise. He was giving me the job because he had a vision and he needed someone that would know how to execute it. And so I was the executor. But all of my experience with strategic planning, budgeting, and HR was just what he needed. I was in that role for about a year, and Secretary Tennis left his position, and Governor Wolf asked me to step in as the secretary of an agency. So 1 year experience, which isn't a whole lot doing this work. And there I was leading an agency of people through a somewhat difficult time when it comes to substance use disorder, right? We were hitting the peak of overdose deaths in Pennsylvania in 2017, right at that time. Also at that time, Governor Wolf was proposing to consolidate all of the health and human service agencies into one agency. So I very much felt like, okay, I can do this. I'm just the Band-Aid, right? I'm just filling this role until we consolidate these agencies, and then someone much more qualified than myself is going to take the helm. As you can imagine, that didn't happen. Those agencies were never consolidated. So I remained as the secretary for the Department of Drug and Alcohol Programs until January of 2023. And then I was given a wonderful opportunity to come work for Secretary Arnold in the Department of Human Services as a deputy for OMHSAS. And again, very much felt underqualified for that position. While I had run an agency focused on substance use disorder, and I felt pretty confident, I knew a good deal about that space, the mental health system was completely new to me. And of course, the Medicaid program on top of that was really new to me. It didn't really work much in that space. So it has been 2.5 years now, almost, I guess, that I have been in this office working with a tremendous group of people. We are quite small as a program office in comparison to the other DHS offices, but our mission is almost every project that DHS works on has some kind of thread that impacts OMHSAS or behavioral health. So it has truly been an honor to be a part of this work. And while I had worked with many of you previously, working with them much closer in this capacity, and I really have appreciated that partnership. And I'm glad that we have each other to lean on as we navigate some of these times. So that's about me. Now I'd like to hear a little bit about Julie, and I know some of you do know her, but not.
Thank you, Jen. Good morning. I thought it might be helpful if I explain kind of some of my path to OMHSAS, because I am very new to state government. Week 5 for me. But I thought it might be interesting to share some of my experiences and what I took away from those and how I hope to bring those perspectives to my work with OMHSAS. So I attended medical school at the University of Rochester in New York. And if you spend any time at all, either as a trainee there or even as an applicant, you will quickly learn that their fame is they are the home of the biopsychosocial model of medicine. And it's this idea that we can't look at illness or disease as purely biological or purely psychological, and that they all have interconnecting forces. And we have to think about those both in like the etiology of disease, but also in how we treat the illness. And I think nowhere in medicine does that ring more true than in psychiatry. And it's funny, I went to medical school thinking I wanted to be a pediatrician. So I set my 3rd year, my clerkship year up. So it was all peds related. And so my first clerkship, my first experience like in an acute hospital was actually my psychiatry clerkship, and it was on an adolescent unit of a state hospital. And I was like, this will be great when I'm a pediatrician. It's gonna be so helpful, right? Little did I know. But I remember the state hospital, I remember it for two things. One was this focus on recovery that they had, and the focus on helping their patients achieve purpose and really meaningful lives. And I remember kind of walking through their kind of like rehab building, and they had patient artwork like hanging up, and the importance and the pride that the hospital itself took. And the other thing I really remember is that it was a 3-story hospital that was pretty new, and it was built right next to the very kind of scary institution, like multiple floor old psych hospital. And it was kind of this a really interesting visual juxtaposition of this is where we have been and this is where we are now, and think about where we can go. And so I really credit kind of my time in medical school as I feel very fortunate that my clinical eye is kind of grounded in that biopsychosocial model and is grounded in recovery. And so then I did my residency in adult psychiatry in Rhode Island at Brown. And so Rhode Island is a pretty small state, which meant as residents, we got to go everywhere. It also meant we got to be part of care teams in a variety of different settings. So, we worked at the VA in the 24-hour psych emergency room and, the capital of Rhode Island, which is small, but still, right? It's a 24-hour emergency room. And, community mental health centers and app teams. And so I got to see and be part of care delivery for folks with mental illness in a variety of different settings and with a variety of different services. And during that time, I became more interested in the medically ill and the older population. So then I came to Pennsylvania to do a geriatric psychiatry fellowship at UPMC in Pittsburgh. And I stayed on faculty there for a couple of years after that, primarily doing consultation liaison work at one of their teaching hospitals. But I had one morning a week at a life program, kind of like, so it's a living independence for the elderly. And it's this program that's designed to keep individuals who are Medicaid eligible, but who should also be living in a nursing home because they have this many medical illnesses and comorbidities, living in their homes with this kind of all-encompassing program of care. And I was their consulting psychiatrist, but I felt like so much like part of a team there. And it was great. It was so awesome because this program did really cool things with patients. And by really cool things, there are things that are like, yes, of course a health program should be doing this, but I'll give you an example. You have an elderly person who is forgetting to take their medicine. And, I talked to the clinic nurse, I'm like, oh, they keep forgetting to take their medicine. And they're like, we'll order an alarm pill box for them. And I was like, what is this place that they are just gonna order an alarm pill box for this individual in their program? And it kind of showed me that if you give trust and flexibility to providers, how programs can really be creative to take care of the whole person, right? And to keep that whole person in the community. No billing code is going to cover an alarm pill box, right? But if you have the flexibility to do that, you can do so much more for folks. And then, I was there for a few years, and then we moved here to the Harrisburg region, and I joined the faculty at Penn State, and I became an inpatient psychiatrist at PPI in Harrisburg. And I worked on their mature adult unit, which was code for over 50 or medically complicated, or in your 3rd trimester of pregnancy, or maybe we have a bed available, right? It's kind of a catch-all. I kind of catered to more medically complicated, complex folks. And I really felt like I tried to ground myself in recovery-oriented care and take a very much a trauma-informed stance in the care of our patients. And I also figured out how important it was both to kind of work with the team in the hospital, but also the patient's team outside of the hospital. So what does their case management team look like? Where are they living? And kind of how important it is to take a collaborative approach. And then also, while I was there, I had the opportunity to work on a civic wellness and voter registration initiative and kind of develop this program over the course of a few years. And I've talked to some of you in this group about that. In addition to feeling like that is like a baby of mine that I left when I came to OMHSAS, it was a wonderful program to be a part of because it really made me start to think about what does recovery-oriented care actually look like for our patients in the community? What actually happens when they leave our hospital? How do they feel connected to the community? Do they feel a sense of belonging? And how do they feel a sense of belonging? And so while I started having kind of more of these musings, I also started having more of my own thoughts of like, what am I doing to contribute to this? What can I also be doing differently to contribute to this idea? And, you know, fortunately for me, I started having these musings at the same time Dr. Adair decided to retire. So, you know, in a sense, timing is really everything. And so then I was very lucky in that I was able to end up at OMHSAS, and I'm so excited to be here and work with Jen and her team and to continue to work with all of you to better the mental health. I'm gonna turn it back over to Jen now that I've told you my biography.
We didn't even rehearse this, but the way that she just described herself, she cares about, is what shined through in her interview. And it was exactly why we said, this is the person we need at OMHSAS. Because in addition to kind of having responsibility for the Medicaid program in Pennsylvania, you know, is a big enough chunk of work to think about. We also have 7 facilities that we staff and run. So 6 mental hospitals and 1 long-term living facility. And we are so committed to the individuals that reside in our facilities and ensuring that we are not their permanent, that we are one in their journey, and that we are constantly focused on what's the next step for them. How do we get them well enough to move on to another facility? And our staff are really, really committed to that. So when Julie was describing project that she just talked about around voter registration and the need to be integrated into the community, it was just like, oh, like, you know, the light went on over her head and the angels were singing. And it was just exactly what we needed for our office. So
Yeah, I mean, how
really
could it,
excited that she's on board. I'm going to talk a little bit
if
very
it's not
high
cutting in
level
here, it's
about the goals that we have in OMHSAS
Spanish.
and a few of the things that we're working on to support that. And then I'm going to let Julie describe how some of the work that she's going to be doing is going to support those goals as well. So the 3 goals that we sort of use as our North Stars are fostering collaboration, building access and capacity, and modernizing the behavioral health system. So in terms of fostering collaboration, when I stepped in to this role at OMHSAS 2 years ago, I was the 7th deputy secretary in a 6-year period of time for OMHSAS. There was a lot of leadership change. And some of that change was pretty dramatic. It's a passing one of those. And so when I started meeting with my staff, you could almost feel the brokenness, the heaviness that came with the work that they felt they were charged to do. And so fostering collaboration became one of the most important things that I felt we needed to work on to get back to a place of strength as an office. We needed to work on our relationships with our stakeholders, with people with lived experience, with our county partners, with our providers, with other agencies within state government that touch the work we do, and even with other program offices within the Department of Human Services. We had gotten to a place of almost being a forgotten entity within DHS. Because the leadership was just so inconsistent. And we were kind of waiting to be told what to do without really a plan of what we needed to drive forward with. So building some of those collaborative relationships was so important, and we're continuing to work on that. Some of the things that we've been working to do is get stakeholder input earlier when we're developing bulletins. So just recently piloted a process where we actually put a document out for stakeholder review before the document gets finalized. What a novel idea, right? So we're hoping to prevent what had happened with that 302 bulletin and the myriad of issuances that followed. And I know you'll talk about that specific topic later this afternoon. But it's really important to me as a leader and to me as a person that relationships take center stage. And, you know, as we start navigating some of these really difficult times, those relationships become more important than ever. So I'm thankful that we've got about 2 years under our belt of preparing and building some of those relationships so that as we head into what will probably be one of the most challenging years of my career in state government, we've got a good solid foundation. The second goal was building access and capacity. So one thing that I didn't tell all of you in my introduction about myself is that I'm also a mother and a grandmother. I have 8 children and 1 grandchild. Of those 8 children that range in age from 2 to 26, I have a daughter who has an intellectual disability, and I have a son who has ADHD and autism. And I have 2 other children that consume behavioral health therapy services for anxiety and depression. So I am no stranger to what it means to try to access services. And interestingly, my personal journey through finding some of that access, particularly for my young son, happened right as I took this position at OMHSAS. So I was living it professionally and personally. And that gives me a very different perspective from most people, because I very clearly understand the importance of making good policy decisions that benefit the whole, and doing so within some of the constraints that we have within state governments. All right, Julie, you'll learn about those. But balancing that with the people who are at the other end of the decisions that we're making. So in terms of what we've been doing to build access and capacity, one of those things has been working diligently on the crisis system, which has been very hard, because to build a new system and to adequately build that continuum of services, what do you need? Money. What don't we have? Money. So I think we've done a pretty remarkable job at building up the 988 system, which is one component of that crisis continuum. As far as states go, we rank quite high in terms of, you know, meeting the parameters for us and the answer rate that they like to be seeing from states. So that's really good news, because we're a big state. We have 14 call centers right now. Our answer rate hovers right around that 90% mark. So that means we're answering 90% of the calls that come in. The other 10%, some of those are calls that actually never get answered because someone hangs up before anyone answers the call. And then some of those roll to the federal or the national backup 988 line. So anyone who's on the phone will get the answer. 90% of the time, that's someone from one of our call centers. So we're doing fairly well with 988. Text and chat, we've got some room to improve, but we're onboarding 2 more call centers with that capability here in the next 6 months. The areas that we've struggled a bit more are around mobile crisis response teams and the emergency walk-in centers. Mobile response, we have mobile response in all 67 counties. Some of those are not 24/7 response. Most of them are, but some of them are not yet. Of those that are 24/7, sometimes it's not the ideal kind of two-person team. It may be a one-person team. It may be a virtual option where if EMS is dispatched to a scene, they have the ability to, through an iPad, call an individual who might live halfway across the county to be that behavioral health response. So we have some room for improvement there, and a lot of that is driven more by workforce challenges than it is anything else. The walk-in centers, those are the things that take a lot of dollars. It takes a lot of money to build it, and it takes a lot of money to maintain it and to run it well. We've certainly seen that. We've seen some success with new facilities being stood up. I think the biggest challenge is nobody really knows how we're going to financially sustain that model. Because we're still in a place of having difficulty billing private insurance for those services. So, that's something we're going to be working on. But that's one of those things that sometimes takes a back seat when we're in the middle of these kinds of crises, that we're having to try to figure out, how to keep people enrolled in Medicaid, let alone trying to figure out, how do we get private insurers to move on something they're not interested in moving on. Also, in terms of building access and capacity, I mentioned my personal experience. Something that we really value is the input from both our Mental Health Planning Council and from the MAC, which is the Medical Assistance Advisory Committee, in understanding what are the needs, where is the capacity lacking, how can we do better getting people access to these services. I will tell you, I think we're going to face a tremendous challenge when it comes to access in the next couple of years. There are a lot of Pennsylvanians who are very worried about their information being provided to the Medicaid program and how that means the federal government will utilize their information. So, I'm not talking about undocumented individuals, because remember, undocumented individuals are not eligible for the Medicaid. I am talking about documented Americans living in Pennsylvania who are fearful that their information will be shared and used inappropriately. There are also challenges when we get to the change in enrollment frequency. So HR 1, or the One Big Beautiful Bill, contained language that requires eligibility to be reviewed every 6 months, as opposed to every 12 months. So that means individuals enrolled in Medicaid now have to go through that re-enrollment process every 6 months. Now, I can tell you, as a mother of 2 children enrolled in the Medicaid program, that is no easy feat. And I am pretty technologically savvy. I know the system pretty well. I keep good documentation because remember, I'm an accountant at heart. So I keep every medical bill filed nice and neat. That process still takes me days, if not weeks, to complete every time I have to renew it. And I will tell you, there are some not nice words being said typically when I'm doing it as well. It's very frustrating. The system doesn't work the way you want it to work. Things don't populate correctly. Things don't save correctly. And now we are asking some of our most vulnerable individuals with access to the least amount of resources to do this twice a year. That doesn't seem like it's promoting access to me. So we're going to have some work to do to partner with our stakeholders and figure out how we get the message out there about the importance of completing this paperwork? How do we make community organizations more accessible for people that need help in doing that? And really, how do we provide the right staffing at our county assistance offices to be able to handle this work? I mean, this is twice the workload that they're going to be faced with. So we're going to have some bumpy roads ahead, I think, with access to care. And then the third goal is modernizing the behavioral health system. And a lot of times when I say modernizing, people assume I'm talking about technology. That's not really what I mean by modernizing. Certainly technology is a piece of that. But there's also a component around modernizing our policies and procedures. So some of the work we've been doing in that space, back in 2024, we implemented for the first time an electronic health records system in our 6 state mental hospitals. I know that is unbelievable that it took us until 2024 to do that. But a huge accomplishment for us, huge. Certainly reduces the risk of errors that can be done through manual paper-based processes. It speeds up the availability of information. So if you're a doctor treating a patient in one of our facilities, you now have all of that information right at your fingertips without needing to comb through files or rely on your memory of having treated that patient. So lots of really, really good things that came with that system. You'll hear Julie talk probably just a little bit more about that when she talks about some of her goals. In terms of non-technology related items, we've been working really hard to chip away at either non-existent or outdated regulations. We are a pretty small business, and we had about 3 positions that were focused on regulatory update and legislative analysis. So the 3 positions from our whole office. We pumped out a whole lot of regulatory packages, and some of those positions have been vacant for part of the 2 years that I've been here. So we were able to get the PRS regulations promulgated last year. It was a great victory for us. We are in the midst of updating the PRTF regulations, psychiatric residential treatment facilities. They have been through the first round of review with the Independent Regulatory Review Commission. We are updating them. Next step will be to send it through for final consideration. We have just recently published the first of 2 crisis regulations. So there are 2 pieces to the crisis regulations. The first, which is out for public comment now, is more the programmatic side of the regulations. So it addresses things like staffing, qualifications, facility requirements, things like that. The second package, which hopefully will be coming in the near future, is the payment regulation side of things. So that's related to Medicaid payment rules and reimbursement for those services. We also have drafted and ready to go what we call the 5100 regulations. Those are related to confidentiality. And that came on the heels of Acts 32 and 33 that were passed back in 2022, I think, related to mental health and substance use disorder confidentiality, and need to align those things with HIPAA. So we have that package ready to roll. And then we're beginning to work on our inpatient regulations. So that's a whole lot of work for really less than 3 bodies to be working on. In terms of processes, we have a new director of community hospital operations. So that used to be Phil Nader, if that name sounds familiar to you. Newly hired into that role is a gentleman named Paul Minnick. Paul is taking a close look at different policies and procedures, and I think Julie's going to talk a little bit about how she's going to be assisting with some of that work. So that's sort of generally those 3 guideposts that we work towards at OMHSAS, and everything we do in some way supports one of those three goals. So I'm gonna let Julie talk a little bit from her perspective about how the chief psychiatric officer or medical director, we use those two terms interchangeably, is gonna support some of that work moving forward.
Thanks, Jen. So I kind of view the medical director's role as like, how can I further OMHSAS's general goals, and also kind of how can I further them while also working within the same framework. So Jen started with collaboration. So I think that's kind of a nice place to start. So when I think about who is it important for me to collaborate with, I get this kind of image of these concentric circles. So I'm gonna walk you through them. And so if we start with kind of the closest circle of OMHSAS, those are really there's obviously like within OMHSAS and being a clinical perspective or those regulations and things like that. But really I'm talking about the state hospital system, right? So like Jen said, we have 6 state hospitals and 1 restoration center. So we are directly responsible for the care of about 1,500 individuals. And Pennsylvania is a big state, right? And we all 7 of these facilities share that patient population. But right now, I think, because of history, they function a little bit as islands. And so the idea is, how can we bring these islands a bit more together? How can we systematize some of our policies, some of our procedures? And definitely, how can we optimize our electronic health system now? That is kind of probably the main thing we are focusing on, myself and Paul, and the CMOs and CEOs of each of those institutions. And I think that's really important, A, because it's going to provide better patient care, but B, it's also going to give us data, right? And so with data, we're going to be able to actually act on those numbers and think about, well, how accessible are institutions? Where are our folks going when they leave? Where are the needs? And we can kind of back that up with concrete numbers. So as much as someone can be excited about an EHR, I'm excited about the potential that brings. And then if you kind of travel with me to the next, ring outside the layer, Jen had also mentioned how OMHSAS is one of many offices within the Department of Human Services. And again, I come back to this idea of, mental health cannot be treated in a vacuum. And so many of our individuals that have mental illness are also struggling with other things, right? So whether that is a developmental disability, whether that is some really, horrible chronic medical condition that's leaving them unable to live independently, whether it's a youth in foster care who's been through trauma and maybe has some behavioral dysregulation. We have a lot of complex patients. And so there are many program offices within DHS that have medical directors. And so I've started kind of conversations with those folks because we share these complicated patients. And so in sharing those complicated patients, we also have to come together to work to find solutions for them. I actually met with the medical director of the Office of Children and Youth for the first time on Friday. And she was telling me that they kind of had a new she was like the first medical director, and she came on board in 2024, in the summer of 2024. And then Dr. Adair retired in the fall of 2024. So really there's never been a time where both offices have had a medical director at the same time. So we're both very excited for that. Right, so there are these opportunities for collaboration with the other medical directors in the other offices. We share the same patient, but we can also share a lot of the same initiatives and strategies. Next ring out would be our behavioral health managed care organizations, the BIMCOs. They are the ones that we work with, who then work with the providers to provide all this excellent psychiatric care. And so I think certainly there are challenges that they face, and they're probably very similar challenges. So we want to start or restart those opportunities for problem solving and collaboration with the BIMCOs as a whole themselves. And then also we can start to address some of those challenges through our population health needs. So that's another very exciting area. And then my last ring is really the providers, right? And that's all here who knows who's on the ground. You are the ones working with our individuals with mental illness. So I really want to hear what you have to say, the solutions that you have, the challenges that you're facing. So I was so excited to be invited to come here. And I want to come listen to all of your conferences, actually. I just want to know I can register. Because it's so important to know what you all feel is important. What are the challenges you feel we need to help and work together in facing. And I really think through, those collaborative means, through those, concentric circles that I just talked about, that's how we're going to achieve those other two goals of helping make behavioral health care more accessible and modernizing and streamlining the system. So that's what I'm hoping to do.
Thanks, Julie. Such a breath of fresh air she is. So I want to keep us moving to get to some time for questions, but there are just a couple more things that I wanted to touch on. One is related to, as Ken referred to them, the mutual impasses. I thought that was a really, almost makes it sound like it's a mutual impasse. So we are at a very interesting moment in history. One that I certainly cannot remember for sure in my professional career, maybe in my lifetime, where we've had both a state budget impasse and a federal budget impasse. There was a time, I think it was under the Rendell administration, where we had a partial state budget and a federal impasse that overlapped, but it was for a very brief period of time, and we did have a partial state budget passed. Certain line items to be funded, and they were still squabbling over a few other things. So this is the first time in my memory that we've ever not had a budget at either the state or federal level. And so much of it coming down to politics. And that makes it really difficult for us as state agencies and really important funders of the behavioral health system. Try to keep things moving in a positive direction and to keep people hopeful. I think the longer that this trudges on, the less hopeful everyone feels. I was on a call just late last week with some of the single county authorities and heard from one of them that on Friday afternoon, they were laying off a third of their staff. And that they wouldn't be able to continue to function past November 30th if there was no budget by then. That they would have to cease their operations. These are dire circumstances, folks. And I wish I could tell you that I had some really positive news about when we can expect something to happen. We had heard that there was a really positive meeting last week at the state level. That there seemed to be some movement toward a compromise, but I haven't heard anything since then. So, where we stand is still an impasse. I've been asked to offer what my feedback is on what the sticking points are, and I won't venture to do that because all I'm hearing are the same rumors that everybody else is hearing. I'm not part of those discussions, so I don't know officially what they are. What I will tell you, absent, being part of those discussions, is that, one of the biggest cost drivers of Pennsylvania's state budget is, in fact, the Department of Human Services. We're a really big chunk, specifically the Medicaid program. And year over year over year, that has been one of the areas of debate. Do we really need to spend this much money to fund this program? And realistically, healthcare costs don't ever go down, right? So anyone who thinks that the Medicare or Medicaid program costs are going to ever decrease, I won't finish that sentence. Yeah, it's not going to happen. So, whether or not that specifically has been part of their conversations and sticking point, I don't know, but I can tell you that it typically year over year is one of the questions that they ask is, why are these costs going up so drastically? Unfortunately, not having a state budget means that we're in a pretty sticky situation, especially when it comes to the health choices program. Because typically about this time of year, we are setting rates and negotiating those rates for calendar year 2026. The way that our agreements run with our primary contractors is on a calendar year basis. Well, at this point, it's very difficult to set rates for an entire calendar year when you have no idea how much money the General Assembly is going to appropriate for that. So, you know, things are really tough for us in terms of trying to set those fair rates. Are tough for our primary contractors and for our managed care organizations who, you know, really strongly feel that they need some significant increases to ensure that they're not incurring losses. But without a sense of what the state budget will be, promises can't be made at the state level about what we can and can't fund. In addition to the Medicaid program, counties are really struggling to fill some of the gaps that typically our mental health base funding would be helping to fill. They're using county dollars to do that. They're floating loans to do that. They're cashing in bonds to do that. So it's a really, really tricky time right now with, at this point, no clear end in sight at either level. I also wanted to touch a little bit on that one big beautiful bill. I did mention the fact that, you know, one of the changes that came with the passage of that bill was the renewal required every 6 months now instead of every 12 months. So that would be a huge impact to our system. I do suspect we will see enrollment dropping as a result of that. Folks who either just don't meet the deadline for providing their documentation back, or folks who say this isn't worth it, you know, not interested. The other big piece of that bill that's getting a lot of discussion is around work requirements. And this is one that I think will still require some significant discussion and some questions to be answered in terms of how that will impact us directly. So in the bill itself, there is some language that said something to the effect of, this doesn't apply to people with a substance use disorder or a serious mental illness. And I'm using those terms. I think the bill used more derogatory language, if I remember correctly, but you get the point. However, I don't really know how they're defining that. I also want to be careful that we don't see that phrase and think, oh, good, that means, you know, behavioral health is protected. Because even though the work requirements may not apply to someone receiving Medicaid benefits because of a behavioral health diagnosis, individuals who will be impacted by that may in fact also have behavioral health needs that perhaps haven't been diagnosed, perhaps they're not receiving treatment for those, or perhaps they're now experiencing behavioral health needs because of some of these other things happening in the nation right now. So there will certainly, without a doubt, be indirect results and consequences of those work requirement changes to the population of people that we serve. I think it's a little difficult to predict exactly what that will look like, and we'll just kind of have to be on the standby for it. I'm happy to hear that you all are continuing your resuming weekly calls. I think that's a really important place to help lift some of those things up to us, things that you're hearing about from your patients. That would be helpful in advising the department about what we could do to be supportive and helpful. So the last thing I'll say about the One Big Beautiful Bill is a reminder that many of the effective dates within that bill are sometime in the future. Some of them start, 26, 27, 28, but several years out. So as with any piece of legislation, there is always an opportunity to pass another piece of legislation that changes a piece of legislation that has been passed, right? So there is still an opportunity, I think, for some advocacy work to happen. And the potential for some of those dates to either be pushed back or perhaps some of the requirements being revisited altogether. I don't think this is a time in our history where we should simply accept the fact that these were decisions made by individuals in 2025 that are gonna affect the nation in 2030, right? We still have an opportunity to make that change. So I think that's a really important point to make. Let's not get too complacent with accepting that, oh, this was passed in a bill. Well, they have the ability to pass a different bill tomorrow that negates what was passed yesterday. So there's still an opportunity. We at the department continue to have to work toward those goals. A lot of what they're requiring means system changes, which take time and money to budget for. We don't have to staff up for some of these things. So we still have to, make some preparations, assuming that those things will become effective. But that doesn't mean the pushback should stop. If we really don't think those are good decisions, we need to keep messaging that and doing so as loudly as we can. The last piece I'll say before I open it up for questions is just a quick update on the four walls situation. So the four walls rule is a federal Medicaid payment requirement that says in order to be reimbursed through Medicaid, a clinic must either have the provider or the recipient of the services located within the four walls of the clinic. During the federal public health emergency, that requirement was waived. And that's what allowed during COVID, providers and individuals to remain in their homes to deliver and receive services. When that public health emergency ended, so did the ability to waive that federal requirement. So we've been working diligently alongside all the other states to come up with a solution to allow for telehealth services to be delivered. And fortunately, the federal government, for the most part, has said, yep, just keep working towards it, keep progressing, we're not gonna hold you accountable. We don't wanna keep living on borrowed time. We don't wanna keep living in their good graces. We actually want to comply with the regulations. So there were two parts necessary in order for Pennsylvania to be compliant. One of those was submitting to the federal government an exception request to allow Pennsylvania's behavioral health clinics to not be bound by that federal payment regulation. We did that at the end of March. We received approval, and that change was retroactive to January 1 of 2025. So as of January 1, 2025, in the eyes of the federal government, we received an exception to those payment regulations. The second piece, though, that is necessary in order for us to be completely compliant is that at some point in time, there was a state regulation created that mirrored that federal payment regulation. So even though we fixed the federal regulation component, there is still a state regulation that requires either the provider or the recipient to be located within the clinic. So there were two paths we could take to fix that state regulation issue. One is revise the regulation. Well, it takes between 18 months and 2 years to revise a regulation. We did not think that that was the most expeditious pathway. The second alternative was to pass a statute that eliminated that language from the regulation. That seems like an easier mechanism, or so we thought. So there has been a bill, House Bill 1590, out there for over a year now. RCPA has been helping us to advocate for, along with many providers. If they pass the bill, it creates the fix that we need. That bill was passed by the Senate. It was moved to the House. When it was moved to the House, it gets assigned to the Health and Human Services Committee, where it has to be voted and approved by the committee before it goes to the full House vote. We can't get it to leave the committee. Senator Brooks is the chairman of that Health and Human Services Committee. I'm sorry, I misspoke earlier. It passed out of the House. It's in the Senate. We need it to be passed out of the Senate. Senator Brooks is the chairman of that committee. She has not yet put it for a vote. So if you're ever interested in advocating for that bill to be moved out of committee so that we can all officially be compliant, both at the federal and state level, we would be oh so appreciative of that. Yes, sir.
So in the absence of that second piece, the federal section would allow with, you know, repeating federal law. Is the 1590 just trying to clean it up so it pops up, or is there a good?
Yeah, I mean, we need the 1590 to clear it up because we don't really know. We assume that the federal government would not take action because there's a state law existing, but we actually don't know that. And we're in a very different world in this federal administration, where decisions aren't always made in the same logical manner that we had been used to for a long time. And frankly, many of the staff that we worked with are no longer employed at those agencies. So we don't want to take for granted the kinds of partnerships and what we've known about the interpretation of things at the federal level, because things are just. Valerie has stood up and she is ready to assist with questions. So that was good timing.
You know what question?
It's not.
Oh, it's not on. I just. You know what question I'm going to ask. I ask all the time about the funding for the suicide hub. 988. Do you have any updates?
So right now, Pennsylvania's 988 call centers are.
She just wasn't-
federally funded.
It's on. You're fine.
Grant specific for that purpose. At this time, every federal grant or federal budget proposal, both from the House and the Senate, does in fact continue to include that funding. And we feel pretty confident that that funding will continue to flow to states. So I believe that we will be okay for at least one more federal fiscal year. But it is imperative that we figure out a sustainable solution in Pennsylvania, because if we don't continue to get those federal grant funds, we have no backup plan. And that's another piece of legislation that's been floating out there for 2 years at least now and getting very, very little traction.
Well, specifically, we've talked about the expansion of text for youth. I don't know if that can occur, plus also the Trevor Project line, how that's the state's kind of doing the workaround.
Yeah, so we are currently in the process of training our existing call centers. So what Deb is referring to is when the federal administration ceased to allow for that option for LGBTQ plus youth to directly reach someone to address their specific needs. What's been happening in the meantime is they get connected to one of our 988 call centers. If the call agent is not able to address their unique needs, the call agent will directly transfer them to the Trevor Project. So the Trevor Project has maintained relationships with states and will still continue to accept those calls. The longer term solution was that we were working with the Trevor Project and some other entities to provide some of that more specialized training to staff within our specific call centers, so that we would hopefully be able to handle as many of those as possible in state without even needing to transfer to the Trevor Project.
We have an online question, from Jeff Natalie, We Found Help. So counties and SCAs are operating at the edge of viability. Without adequate capitation, provider networks will continue to shrink, jeopardizing access and ultimately increasing costs elsewhere in the system. Education, justice, housing, homelessness. What can providers do to support OMHSAS and helping legislators understand that maintaining health choices rates is actually a cost containment strategy, not excess spending?
Yeah. Preach it. Yeah, I mean, I think there absolutely is a knowledge deficit within our state general assembly and federally, but more specifically on the state level. You know, they see those really big numbers for the Medicaid program. And again, you know, as someone with an accounting background, if I had not known human services and I was on the appropriations committee and I was looking at the budget and ends don't meet, the first thing you do is say, well, let's look at the biggest piece of the pie, right? It's easier to trim the biggest piece of the pie because it should hurt less. That's just logical thinking. So you don't blame them for that thinking. The challenge is that we haven't really done, and we, I mean the collective we, haven't done a really good job of connecting the dots for them about how important the funding of that program is and how detrimental it can be if we don't fund it sufficiently. And unfortunately, some of that would require predicting the future. You know, what would happen if we don't fund this program? And that's always a difficult narrative to try to express to lawmakers that, well, if we don't, this is what could happen kind of thing. It's sort of like trying to explain the value of prevention funding. It's really, really difficult. So I think it's continued education, constant education, and education from a variety of different parties. So they need to hear from people and families with lived experience who live in their districts. That's very important. They also need to hear from providers who are sometimes small businesses or large employers within their districts to say, hey, if this place closes, look what's going to happen to our communities. They need to hear from hospitals and health systems about the impacts to emergency department boarding and cost, because if there's nowhere else to go, that's where people are going to show up. So, you know, I think early, constant education is important and keeping it as simple as you can. Remember that these are individuals that don't know the program like we know the program. So when they say like, speak it at a 6th grade level, speak it at a 6th grade level. And that's not because we're insulting their intelligence. It's because this is a really complicated system and a complicated program. And when you can boil it down to the really important key points, like these are the impacts of not funding this program, that's always helpful. And it will stick with them in a different way than providing them a 10-page white paper that you wrote about, you know, the psychological impacts of not funding Medicaid. You know, quick, short, 1-page, 2-page max. Good question.
You know, I think we're coming up on time, and I don't know if the speakers who are next are here. They're here. Okay, great. So I'll make this very quick. First of all, I want to just say, in terms of fostering collaboration and connections, I really appreciate you guys coming and speaking with us and telling us what's happening from your perspectives and where this is going. I was going to go into a whole long thing about collaborations, but I won't. Other than to say that, particularly with the issue of the work requirements and also the re-upping of people, I'm hopeful that we can build an additional ring to the collaboration that you guys have been talking about, and that is particularly to include the primary medical health services out there that I would like to convert to being not primary medical health services, but primary health services from a whole person perspective. And I want to say this for 2 reasons. One is that I think that it will be extremely helpful in addressing, especially if we talk with the FQHCs and other rural community health centers, we will be able to address at least some of the people who we're going to worry about falling off because of work requirement. If they're going to show up, that's a place where they're more likely to show up. And we need to figure out how to support that activity. And the second thing is that it's really clear that there is a tremendous amount of work that's done on a mental health level that could be buttressed and increased in these settings that would take the load off of some of the specialty care. And I think then reduce some of the challenges that we face, but we need to be bringing those folks in as much. I would actually argue that they're handling most of the mental health challenges that are occurring in the state. The more severe ones obviously come to the specialty services, but the ones that they're seeing are on their way to becoming severe or are being maintained after they recover. So this is a critical part of the community that I'm hoping we can have a conversation about. And I'll just say this is an open invitation to both of you. We have we've been partners in the formation of the Coalition for the Common Health, which has been pursuing a strategy of whole person primary health services with mental health and behavioral health services at the foundation of those. And you're welcome to join us as help us understand those conflicts and challenges that you're facing, and then we can figure out how we may be able to be helpful on that level.
Yeah, that would be great. Thanks.
All right, one very quick question from,
I don't know.
it's gotta be quick, be a quick question. So, what I'd like to hear is your, view or where you see family fitting into the picture, because I haven't heard that yet. So, again, having had family, been involved in many systems in many different ways, I understand that it's much better in the children's system than it ever was. But how about in the adult and older adult? That's not, I don't hear the lifespan approach being talked about and the importance of it, or collaborating with families around these issues.
Yeah, that's a great question. We certainly have a couple of family-specific initiatives that have been on our radar for quite some time around creating some certifications. I know that's not what you were talking about specifically,
Well,
but
no,
I'm
because
mentioning that.
it's not gonna happen now, so but there has to be other ways to collaborate.
Yeah, I agree. So, I mean, currently, I would say most of that involvement and input is coming through things like the Mental Health Planning Council, where, a large majority of the council themselves are either people with lived experience or family members. So if you have specific ideas about how to best engage families in a meaningful way, that's something I'd love to engage in conversation with you about. I think for our purposes, historically, there hasn't been kind of one association, one group of people that we kind of historically have leaned on in that space. So we often find it hard to figure out who's the right person, how do we connect with these folks? So if you can help us either build that or connect to something that already exists, that would be really helpful.
Thank you.
Great. Carl, I warmed them up for you.
All right, thank you so much to Jen and Joel, thank you very much.
You hear me? It's on? Okay. Sure, people have to move the thing down. I just found out a couple minutes ago about doing the introduction, so I can tell you the things that are shown on here about them, but I know them a different way. So, you can look at, Sally has, Deputy Secretary Kozak. I always get in trouble for just calling her Sally, but Sally is an RN. She's been Deputy Secretary for the Office of Medical Assistance Programs for a long time. And I know Sally well when I have been involved in the MAC, being the chair of the MAC, also being on the consumer subcommittee. Without getting into all the specifics, there aren't too many people who care the way Sally does, because if you work at DHS, you don't do it for the money, that's for sure. You do it because you have a calling. So Sally has been involved in a lot of important initiatives, including Medicaid expansion and working with SNAP and doulas and all kinds of things. So she has a lot of stories she could tell you. But Sally is just a tireless advocate. So that's what I can say about Sally. I'm sure she can tell you more. And Carl, I know Carl a little less, but Carl is also the person that is kind of the hot guy right now, and the fact that everything that's going on with the big bad bill and all those requirements falls in the lap of Carl's shop at the Office of Income Maintenance. And so he is definitely the go-to person. Any question, if he can answer it, he'll look at that for you. I always help people with insurance and other questions they have, but now his responsibility is, unless you're living under a rock, it's SNAP. So it's SNAP all the time. So without any other further ado, I don't know who is going first or how you want to do it, but is this Sally slides? Oh, do you want the flipper? Do you want the flipper?
I would like to. I made slides on this, anyway. This is forward. It's excellent. All right, thank you. Hello, my name is Carl Feldman. I'm the Director of the Bureau of Policy within the Office of Income Maintenance. We make eligibility policy with public programs. And as was said, we're going to talk about that today. We're going to talk about Medicaid too. Deputy Secretary Sally Kozak, and the Office of Medical Assistance Program focuses on the service that are being provided. I was thinking we would run through the slides talking about kind of the more changes to our programs because of HR 1 and questions about it. I'll be handling the slides, and it's mostly kind of the sequential things that are so. HR 1 2025, E1 big beautiful bill. On July 4th, this was signed into law by President Trump, passed by the Congressional Republican Party. And it makes substantial changes to some of the nation's most essential public safety net programs. I'm going to be talking about them in chronological order. There are more changes to these programs as a result of this law. I tried to focus on those that are coming in the next 2 years that would be probably most consequential to the broad public, but changes to financing are, of course, really critical and to the Commonwealth and subsequently to the program. I wasn't really planning to talk about that today. So I've got some items for the SNAP program, as was said, all SNAP all the time right now, and that's because the law made it so that the SNAP program changes went into effect immediately. It did not put an implementation date. That means the law of the land requires these things that are listed here. SNAP time limit rule changes, SNAP non-citizen rule changes around eligibility, and SNAP shelter allowance rules changes to benefit. We're obviously past October 1, the start of the federal fiscal year, but that's the first federal fiscal year 2026 for which the state is on the hook potentially for funding a part of the benefits that are issued through the SNAP program. This program has been around for many years, and the federal government has covered 100% of the cost, but this law makes it so that states are on the hook. Potentially talk about that. And then fast forwarding to the next kind of date of impact, I guess you could say, federal fiscal year 2027. The SNAP federal administrative match falls to 25%. So typically we get a 50-50 funding match on administrative activities in the SNAP program. That will fall to 25%. That means that the payment for staff, payment for system updates, many of the things that make the program run better and more efficient all the things we want to do for our recipients and our workers and you as providers. That's it. And then also the non-citizen rules for the Medicaid program change. It certainly would have been nicer for us if these could have been at least the same date, but they're not. And so there's going to be an interesting period of time over this next year where there's a change from SNAP, but not to Medicaid. And come closer. All right, meet the mic. That's what the people doing stuff doing this. In 2027, the start of that calendar year, Medicaid community engagement rules. This is a mechanism for work rules in the Medicaid program. Medicaid 6 months redeterminations start. This means every 6 months, people in certain categories of Medicaid must renew, and Medicaid retroactive coverage limitations. That is the sequence of events. So specifically on the SNAP side, a lot of this implementation is occurring throughout this fall. The SNAP time limit changes took effect first on September 1 of 2025 for most of the state. The non-citizen rules take effect today. Policy was released. Then at the end of last week, we only received direction from FNS on Friday of last week, but how to do that. We certainly appreciate all the grace we will give. And the SNAP shelter allowance changes are taking effect this month as well. So let's talk about what these are. Starting with the shelter allowance rule change. So SNAP recipients basically get extra assistance in their SNAP grant if they have high utility costs for their home. And before this law passed, people who didn't indicate what that cost was, as long as they didn't meet a couple specific criteria, would be given a small amount of money through the LIHEAP program that further qualified them for this extra help, the shelter utility allowance. Due to the law, we can now only provide that extra help if the person is disabled or elderly. It used to be anybody could receive it. And the end result of that is that households that have not verified utility responsibility with us will and don't meet that elderly or disabled criteria are going to have a reduced benefit. They can get that back if they show to us that they do in fact have that responsibility. And many households do. They would just need to indicate that to us. And so you can think of this as a kind of standard fair cut to people's benefits. Non-citizen rule change we'll talk about next. This is very similar on the Medicaid side. There's some slight differences, but this gives you a good preview of what we're going to see for the Medicaid program. But because it's starting first for SNAP, you're going to take that today. Prior to this law, there were citizens, non-citizens, and a number of non-citizen categories that receive SNAP. I think the most well-known of this group are refugees. They're in the United States and they could receive SNAP on their admission. People granted asylum could also receive SNAP, and people who were trafficked could receive SNAP. As a result of the law change, only legal permanent residents, Cuban Haitian entrant status individuals, and COFA migrants could receive SNAP. The far away the most impactful thing here is going to be refugee population. Households that have not adjusted to legal permanent resident status will no longer be considered eligible for SNAP. I have a little more to say on the SNAP time limit rule changes. This will be, I think, a little bit instructive because I'm particularly familiar with it to what's going on in the Medicaid space in 2027. But again, unfortunately, these things don't line up perfectly in how they function, and we'll get into that. So let me start by saying that work rules in the SNAP program are not new. Aurora passed in 1996, included work rules for the SNAP program. And at that time, there were a number of ways in which states could indicate that implementing a work rule was not effective for the recipients. But generally how it worked was you needed to either meet the work rule criteria or receive an exemption from that work rule criteria. And if not, you could only receive 3 months of SNAP benefits in a 36-month period. So the first change associated with this, and this is what it went into effect in September 1 and why the majority of the state became subject to new work rules on September 1, is that prior to the law passing, municipal jurisdictions, actually below the county level sometimes, could be waived from those SNAP time limit rules if certain economic hardship criteria were met. Essentially, that meant that if there weren't enough jobs, if the unemployment rate was too high, the state had the ability to ask the federal government. The federal government actually is required to approve a waiver of those rules. And up until September 1 of this year, all but 7 counties and a couple municipal jurisdictions of Pennsylvania were waived from this time. As a result of the law, the lower threshold to get that waiver has been increased. And as of September 1, the waiver we were operating under ended. We were not approved for a new waiver because that new waiver would have been under these new rules, and the entirety of the state is no longer needed. And individuals need to meet their work rule and exemption, or they will elapse the 3 months of eligibility that they have. So that's why we say time. They had 3 months. I can say today, this was not available until last week, that we now refer to these individuals as peers, Pennsylvanians with employment and education requirements. You may know that this body of people who's referred to as ABODs, able-bodied adults without dependents. We don't call them that anymore, and I'll tell you why. So the SNAP time limit population changes. This is a difference into whom these rules are applied. This is effective November 1. And prior to SNAP time limits, we called them ABODs because able-bodied adults without dependents. The federal law made it so that people with dependents will now need to also meet this work. Those are households with a child under the age of 14. It would also increase the age band of individuals to whom this work will apply. Prior to HR 1, the upper age threshold was 54. That has been increased to 64. So as a result, as of 11/1, SNAP time, all SNAP time limited applicants, it phases in for new applicants on November 1. Not exempt from meeting work rules are subject to that 3-month time. And SNAP recipients identified as time limited, they can keep their SNAP by meeting the work rules or demonstrating that they're exempt. Talk about how they might go about doing that. So meeting the work rules, they can do this through work, 20 hours a week or 80 hours a month. They can participate in a work program for generally the same periods of time. They can enroll in school for at least half the time, or they could volunteer to do community service subject to certain events. Here are a list of exemptions that they might need. This would be under the general age bands, the dependent band, which has changed a little bit as I described, being pregnant, having a disability, receiving TANF or unemployment compensation, having status of homeless, being a caregiver, being expected to return to work in 60 days. I want to pause and kind of talk a little bit about that. Unable to work due to a physical or mental health condition. We take a broad approach to that. We understand that, while it's nice to have a doctor that will say you may not be able to work, have as much work capacity because of some mental or physical health condition, not everyone's always able to get in and talk to a physician or a doctor fully. Anyone who can bill the Medicaid program is actually able to sign off on that status for an individual. It's called, the form we use for this is a PA 1921. And if it is properly documented and provided to us, we will accept it. We're not medical professionals. We, in this instance, leave the judgment to clinicians and Medicaid providers. So now I'm going to talk a little bit about the Medicaid program change implementation, as I said earlier, this is going to phase in over a bit of a longer period of time, which feels crazy to say because it's only a year. And if you follow the congressional debates about this, they're saying, well, could we get this out to 2029? But in my world, it feels like, well, this will happen throughout 2026. I can't really speak to what the details of that are because our focus has been so significantly on the SNAP program. But we are going to have to be prepared for that. We're expecting guidance to be issued by CMS, Centers for Medicaid and Medicare Services, in July of 2026. That's at least what the law says. We hope they are able to do it sooner, honestly. That would make our jobs a lot easier. And the first notice to Medicaid recipients on these new rules are statutorily mandated to occur in October of 2026. I don't know much about what we're going to say, but that is the time frame we have to work on. We're going to talk now about the non-citizen rule change on the Medicaid side, very similar to the SNAP non-citizen rule change. Prior to the law changing, again, many non-citizens statuses could receive full medical assistance, and the big change, like SNAP, is in the refugee. That will probably be the most numerous group of individuals who will no longer be eligible for Medicaid full Medicaid as a result of this change. And the category of people whose full Medicaid eligibility will continue, same as SNAP: legal permanent residents, invitation entrants, COVID migrants. If they have not adjusted to that LPR status, they cannot be considered eligible for full Medicaid. We do want to point out, unlike the SNAP program or the Medicaid program, eligible non-citizen households can continue to receive chipper coverage, their children, and they can receive emergency medical assistance, which is not full medical assistance, but is something that they will still be able to get. The retroactive coverage changes occur at the same time, beginning in 2027. Prior to HR 1, Medicaid recipients could use their MA coverage to pay medical bills up to 90 days prior to their eligibility determination. This was kind of a not uncommon circumstance where someone found themselves in a crisis. And due to HR 1, as of that new year, retroactive coverage kind of bifurcated. Right off the bat, we can't provide 3 months of retroactive coverage anymore. The adult expansion population is only entitled to a single month of retroactive coverage. Other Medicaid eligibility categories could receive 2 months, and CHIP could receive 2 months. And it's pretty self-explanatory what this will do. It will just mean that people cannot get their medical bills covered by the Medicaid program to the extent that they were able to do so before, and there's no doubt that that will have a significant impact. The 6-month redetermination rule change, I think this certainly deserves a lot of attention. You may know that right now, when someone receives Medicaid, they must renew their coverage every year, unless they're in a couple specific categories. Vast majority of people receive 12 months of coverage. Individuals in the adult expansion population will now have to renew their eligibility at 6 months when this implementation occurs in 2027. And on its face, I mean, you write down, look at a piece of paper, it's not that different. Someone gets a renewal packet in the mail, they respond to it, we determine them eligible. Sometimes we're even able to determine them eligible ex parte based on data that we have. That's certainly the preferred path. Not always able to do that. But from a functional standpoint, there's no doubt that this will be an enormous increase in county assistance offices. This is an enormous increase in the administrative burden that the recipients face, and will definitely change the face of the program for recipients, because they're going to have to be in touch with us more. We're going to have to be working through their eligibility status more frequently. And unfortunately, people do fall out when it requires some kind of activity. Finally, we'll talk about the community engagement rules. So prior to HR 1, this was not contemplated in the Medicaid program. This is entirely new. And under the new program, individuals between the ages of 18 and 64, and those who do not have children under age 14 in the household, in the Medicaid expansion categories, that's important to know. So I often hear a lot like, oh, is this going to impact households with disabled children or something like that? Those individuals are in different categories of Medicaid, but this really turns the Affordable Care Act Medicaid expansion on its head. They will be subject to these new rules, and they will need to demonstrate that they either meet those engagement rules or they have an exemption in order to keep their eligibility. So what we know so far, and this is limited because we can read it in the law, but it requires a great deal of direction from the federal government. This is what we've read in the law so far. Individuals meeting the work requirement by 80 hours a month or other combined qualifying activities. So work, community service, educational programming. They can have monthly income that would get them through this gatepost of eligibility, as long as it's over 80 hours times the federal minimum wage. And seasonal workers have a little bit of a different calculation, but it's the same concept. So the exemptions that these households will be able to receive, this is not a full list, it's not exhaustive, because there are a number of contingencies that are tied up in how the federal government handles this, but this is what we can read along now. Pregnant individuals, individuals postpartum period, foster and former foster youth, American Indians, veterans with disabilities rated as total, medically frail. This is something of much discussion among states, what CMS will consider to be medically frail. STD treatment, work requirements under TANF and SNAP, parents of and caregivers with dependent children, being a recipient of Medicare, individuals under the age of 19 and incarcerated individuals. So I just want to go over a couple key points for anybody who's been talking or thinking about these things. It's broadly applicable. In all the cases, applicants and recipients will not be subject to engagement expectations. That I think, generally speaking, there's, especially with the work rules on the SNAP side, many people are talking about this. The broad public is kind of paying attention to it. You know, reps offices are doing events, and I think they're trying to helpfully get out the message. There are new rules we're talking about here, but as far as the individual recipient goes, for most people, you know, I can tell you what time frames those will kick in on, but unless they get a notice from us saying that this is expected of you, it will not be held against them in their eligibility determinations. We want to make sure these individuals are keeping their contact information up to date with DHS. This is much the same message we sent during the unwinding, and as a result, we feel we were fairly able to do an okay job at getting people through that unwinding of continuous coverage. They need to report their changes by the 10th day of the month following when the change occurs. That's a general expectation. We want them to download the My Compass PA app. We want them to sign up for notices and texts, because so much of what happens here is contingent on ensuring that the person does what they need to do based on mail, which is still our primary mode of communication with recipients, and it is the official mode of communication if we need to tell somebody they need to do something in order to receive something. And finally, if you are working with others, we do now have communications toolkits available on our website to talk about these changes. There's copy for newsletter and social media content, things like that. If you have something that you'd like to get up there, you can contact us through the MAC or the Consumer Subcommittee or my office, and we'll do our best to make whatever that missing kind of link is available. And then we're just continuing to put more new information there. So I've talked a lot about the changes that we'll see over the next 2 years. I am happy to take questions on this, and I'm sure Deputy Secretary Kozak is.
You think that I actually need a mic, but probably.
For people online.
These are people online, but we know you can project. We can't hear you.
Good morning. Just work it. Good morning. Thank you for being here with us. I really appreciate hearing from you both. And we've enjoyed our contacts over the years, so thank you. My first question is there an estimate at what cost will come to the Commonwealth for actually enacting and providing the type of dealing with the re-evaluations every 6 months? What's that going to cost us as a Commonwealth?
I'm not sure I have anything available on that. If you're thinking it's a lot of money, it is.
Thank you.
Yeah.
Yeah, I don't have specific numbers, but what I will say is it's gonna cost, systems changes in our eligibility system. The other systems that they interact with, and then of course, there's the increased load of the county assistance office, and that will require additional case managers as well. So it's a pretty significant unfunded mandate for the Commonwealth.
I'd heard double-digit millions was.
I'm not sure that it's double-digit billions.
No,
but
millions.
Billions, billions.
Yeah.
Millions, double-digit millions, yes, I'm sorry, I'm getting old and hard of hearing. But double-digit billions, no, but yes, millions, hundreds of millions.
And there's so many of these pieces that each have their own costs. So like we go through the eligibility stuff we just talked about. Every 6 months, work rules on the SNAP and the Medicaid side. So those all have costs associated with making changes and running them. But then that would be paired with the fact that the SNAP benefit level that could potentially have to be paid by the Commonwealth, that is in the hundreds of millions of dollars annually. And also the Commonwealth receiving half of the administrative costs to run the SNAP program compared to what we used to receive. There's an enormous cost shift to the states here across both.
The early estimate I had heard was 300,000 Pennsylvanians would eventually lose their MA benefits due to these changes. Has that changed?
The estimates for that are based on historical projections for participation in work and employment programs. And so I think that's trying to give people an idea of why we think this is bad based on what we know as we go through the process of developing the work and engagement rules for the Medicaid program. I suspect that will be updated.
Thank you. And the final question for me is the new project from DHS is that Helping Hands, some folks in the community. Will that be something that you will be planning to utilize in helping people along through this recertification revalidation process?
Big hands.
Yeah, Helping Hands volunteers, I believe they are.
Okay. Oh, I think you're talking about the messaging. Yeah, the messaging platform. I mean, we're constantly providing them as much content as we can to get out to people through all the channels possible. And I think the idea on that was we did kind of a version of this for the unwinding. And I think folks were happy about how that went. It's a way to get people good and actionable information about what's going on at a broader level. So, I mean, every single day we're sending them things to try and get up and out to folks like yourself. Yeah, absolutely.
Thank you very much. Yeah.
Good morning. I'm Ken Thompson. I'm the Chief Medical Officer for the Pennsylvania Psychiatric Leadership Council, and I'm really very, very pleased that you guys are here and giving us this information. Carl, the way you went through this was the most helpful I have heard so far, so thank you. I really appreciate it. It was the most helpful. It was also the most alarming to get it really a little bit more clearly spelled out. And I have two basic questions. One of them is at the level of the issue of medically or psychiatrically unable to work or disabled. I would love to hear from you your thoughts about the role that clinicians can play in this particular issue because clinicians frequently do two things. One is they don't pay attention to the actual source of the insurance that people have. They're not talking to people about their insurance. They don't think about it. We just try to provide care to whoever walks in, regardless of how they're paying for it. That's a general rule. I mean, the people in the front office may be different about that, but the clinicians, I think, are just not crowding their minds with that. So one issue is, being aware of the challenges that the loss of insurance create. The second thing is around disability is that clinicians, not all, but some, feel like they are supposed to keep people from being disabled. Right? That is in fact something that we do not engage with. And I've run into many clinicians who will not sign people's disability papers for various reasons. And I think we may need to think a lot about how we talk to clinicians about how they understand what their role is and how important it is to recognize when somebody is unable to work on a full-time basis, right? That this is a disability. People should be encouraged to apply for disability, et cetera. So a conversation about disability and medical practice, especially in primary health services, especially in the safety net services, I think would be really very helpful to help build up the clinical workforce to address some of the challenges in a way that may be helpful to this whole process. So that's my first thing I wanted to mention. The second thing is I worked a lot with the refugees. I am extremely proud of this state and my community in Pittsburgh because we've taken over probably somewhere around 20,000 refugees over the last 10, 15 years. We are now not going to have refugees, as everybody knows. Trump has essentially eliminated the category, unless you happen to be a white South African, which to me is such an incredible travesty. Hard to speak about it. But I'm very worried about the refugee community. Large numbers of those folks are in fact disabled. They are not able to meet the citizen requirement at 5 years, which is what it takes to even be able to become a permanent resident. So I don't know how these families are going to feed themselves. I don't know how they're going to get medical care. I'm very anxious about this, and I don't know if there's some ongoing conversations that we're having at the state level to address some of the challenges that these communities, which are by definition already extremely traumatized, who have come to the United States brought here by us with hope, and now we are just giving them the back of our hand. I'm just wondering what the state's thinking about doing about that. So those are two big questions I realize, and you can say forget it, or if you have any thoughts about them, I'd appreciate it.
Well, as far as the refugee community goes, there are limited but other streams of funding that are being looked at. I don't think anything across the board. I think like you're going to see this right now with the SNAP benefits being put on pause because of federal shutdown, can make up for the SNAP program. So it feels odd to say like, well, we're working something, but there are refugee services grants that exist. The Commonwealth receives. We have an Office of Refugee Resettlement at Charlotte Fry's, our state refugee coordinator. Is in constant contact with the resettlement organizations about this. There's some desire to put together some kind of food assistance benefit based on the refugee services grants, but I'm not as familiar with how far that can really go, what the reach can really be. It's such a big gap to be able to make up. I'm not confident I can get all the way there. On the provider side, I guess I'm just sorry that Congress has seen fit that this is the kind of relationship that you should have, I guess, with your patients. And I don't know what the right answer to that is. I'll just say that where it's possible, we're going to try and verify the disability without engaging you. You're all learned people, but if we have information available to us, it's less kind of burdensome for everyone involved. We can do that through Medicare. We can do that through Social Security disability. Many times we even can get, not necessarily substance use treatment data per se, but people might be on staff and receiving substance use treatment, and that information is already known to us somewhat. So that gets us pretty far down the road. Some of these things we can take through attestation. Substance use is actually one of them, which is helpful. But it's really, when you get to people who don't tell us that, they might not identify it as a disability. I imagine psychiatric disorders are very high on the potentialities where somebody hasn't disclosed to us a disability and may actually be able to continue to receive nutrition assistance. And yeah, I don't know what the provider community can or should do about that.
I think that providers and the folks in our office can play a big role in some very basic ways. Making sure that individuals are aware of how to up their coverage. Everybody gets to see everybody's insurance card, make sure they know how to contact their insurance company. And then make sure that we tell our folks that they have to pay attention to what the department sends them. That's one of the big things we find. People just don't read the mail. So I think to the extent that providers' offices continue that message, like Carl, I don't have a suggestion for physicians of what they should or shouldn't document. Make sure recipients know to keep their information current.
I have an idea actually now that we're talking about this a little bit. If your patient summaries indicate anything like that, we actually can use that. So if the patient summary says so-and-so's work capacity is diminished, it's not often that happens, but we don't need the signed form because the summary is already saying that, and FNS takes a really broad view as to what can be treated as provided to us from the client, so it doesn't need to be our. It's like that any form is a good form rule, which can sometimes be, but for this purpose, if somebody's visit summary might say this, or if you structure your visit summaries to say something like this, that would be helpful.
That is something that could be thought and done. We do not generally comment on disability status in a limited way in our summaries, but that is something that in this current thing, obviously is indicated clinically relevant. So that's very useful. That'd be very useful.
Hi, I'm James Fairfax Colombo. I'm a clinical forensic psychologist from Philadelphia. First, I wanted to give a thought on that previous question, then I had a question of my own. One of the things that I always think about as someone who's done some disability evaluations, it's really just a question of like functional impairment, which is a thing that all clinicians will think about in terms of you have these symptoms and how is it impairing you in these domains. So you don't need to say anything about disability necessarily, but if you are careful to document, and this is how it impacts family relationships, and this is how it impacts employment and education and all those things. It sounds like that's similar to what you're saying, is if we can just
it's
have
really
some
diminished capacity for work. I can't recall like the exact language in the CFR. And if you look at the form, the PA 1921, you'll see it written out that way, but diminished capacity for work, it's not like making a statement about the fact that the person is fully disabled, unable completely to work.
Yeah, so the last time I did a disability evaluation, I was thinking heavily about like, well, what was interfering? It was calling out of work a lot for stress. There were a lot of ways that it was impacting work. And eventually I addressed those specific disability determinations, but all the pages in the report before that were really the lead up to like me explaining that impairment. But the quick question that I had, I often find if it's something that relates to behavioral health, that's something that gets slept on. But they will pay attention if it has impacts in other areas. So, and I don't know if you've had time to think about this because it sounds like you're really busy with everything with SNAP, but can you think about any, like what are the ripple effects that you project happening in other domains? So I'm thinking disability is a good example of, if that's a category that we know is exempt, are people more motivated to try to get connected to disability than they might have been otherwise, where they're maybe white knuckling it and trying really hard to stay in the workforce? Or if you're looking at education, do we start to see community college enrollment go up a lot, and how does that strain the system? So can you maybe talk about some of the areas you think this will have reverberations in?
Well, I can't really speak to any of the clinical outcomes or anything like that, but I can tell you something that we're thinking about a lot on the Medicaid side for those workable implementation. 7 is that the law changed, who needed, well, it didn't exist before, but the people who need to meet that work requirement on the Medicaid side is limited to the Affordable Care Act categories of Medicaid, but there's a number of different categories of Medicaid that a person can receive. And I think there's going to be a lot of thought put into how do we make it so somebody can indicate to us that they need? How do we make it so somebody can indicate to us that they can get an exemption? Something I haven't put a lot of thought into, but another route that we at the department need to be thinking about and will be thinking about is how do you make it so that somebody who's actually eligible for a different category of Medicaid can move over to that category? And historically, I think that's been a little fraught because we received 90% match on the Affordable Care Act category. That's what the law that was passed back in 2009 said. And so it's beneficial to the department for someone to stay in that category of eligibility. But if they're not going to stay in it at all, because they're not going to meet some requirement that we have, and they have something that we didn't otherwise know, or there's some way that they can move over, I think that's probably something we want to do. I don't know exactly where that starts and stops, the kind of scope of what a policy around that would be, but it's been.
Good morning. Question about really unintended consequences. For example, additional visits to emergency rooms and the impacts that will have on EDs and hospitals in general, specifically in rural communities where we're already seeing a decline in rural health. Is there a way that Department of Human Services could potentially have some kind of consistent messaging for folks, who are trying to message these unintended consequences of the hits that are going to take? Obviously, we want our folks to be covered, but they're still going to continue to get care, even if they aren't enrolled in the Medicaid program.
So we clearly anticipate that as people lose coverage, that we are going to see increases in ER utilization in particular, because people will no longer have a primary care physician. That care is going to be uncompensated care for the most part. So we recognize that there's going to be a significant visible impact to our healthcare systems across the state. In terms of messaging, again, the important piece is that folks need to re-up and their eligibility determinations and pay attention to what it is that we're sending them. They're going to need to rely on all of the partners in the community to ensure that that happens. I mean, we have Compass community partners who probably need some more Compass community partners that can actually assist people with eligibility. We have messaging out there, referring people to our resources. But again, and we can't stress this enough. It's going to be important that people keep their addresses up to date. It's going to be important that people read what it is that we're sending them. They need to open our mail. And it's going to be important that people understand the basic requirements for work, volunteer, or education, and make sure that gets documented. As Carl mentioned, we're doing some communication toolkits. We already have some available on our website. There'll be more as we move forward. And I would encourage you to check back on our resources often.
I have a couple of anonymous questions from the chat for you guys. So this one's for Carl. So is there a plan to leverage or expand Compass community partners to support the COAs?
Well, we actually this month rolled out some changes that I think will be very helpful over the course of the next couple of years. The first of which will be able to be used or in place for everyone who's using Compass platform, both community partners and just anybody who's logging to submit an application, is a document upload service that basically checks to make sure that the images that are being sent to us are going to work for us. It's not uncommon that we receive images of pay stubs or other forms of verification that we just can't read. And it's nobody's fault. They just didn't know there was a problem with the image. So there's a kind of new set of things that will be checking that, cleaning it up for the worker just to make it easier to read generally, but telling the submitter, hey, like this is not going to work for us. They can actually still submit it. We don't keep them doing that. We just say, please send us that one. There's also an application status tracker that is currently in a pilot with, I think, about 5% of the applications that we receive. And with this tool, you can look up without even having to log into Compass to see what the status of an application you submitted is. There's some other things that we're working on, but that's kind of what we'll talk about publicly right now. So yeah, there is some work being done to try and make these tools more robust for the task at hand.
And then the other question, is there consideration to have the BHOs give their providers enrollment and date data so that the providers to support re-enrollment and protect the revenue?
I think this is kind of a bit, I'm not sure. Are they saying basically, I don't know that we have a mechanism to convey eligibility information directly on a broad scale today to providers. I think we have, what is it, EDS, checks general eligibility, and that's kind of the mechanism.
No, was it, we don't have a mechanism to send out everybody's exact due dates to providers.
So I realize there's probably more questions, but Deputy Secretary Kozak, do you have any prepared statements that you would want to discuss? I don't know if you had any or if you're just happy to continue the
I did
conversation.
have opening statements, but I think we have covered absolutely everything that was in my statement.
Okay.
So.
Is there anything else that you would want to personally add to the conversation before we continue with questions?
I'll add a couple of pieces to all of this. This law has the potential to have a fair number of individuals lose eligibility, and not because they aren't eligible, is because the new rule puts significant administrative barriers in their way. It's going to take all of us to do everything that we can to support folks in removing those barriers, or at least making sure that they're able to clear them, so to speak. Carl talked a lot about the SNAP program, which is where our focus is going forward. But the Medicaid program will begin to face the exact same issues beginning 1/1/26 or 27. And as Carl said, a year sounds like a whole lot of time, but it really isn't. And those people that are going to be most at risk as the Medicaid changes begin to take place in 27 are those that are eligible now under the ACA expansion. Those folks are probably the ones that are at greatest risk of losing coverage going forward. The other piece then, we haven't really gotten around to talking about this a lot because it doesn't start to happen until 27 and ends in 2032, is the reductions that we're going to see in how it is that the program is funded. Right now, our programs are funded through a variety of assessments or provider taxes. And beginning in this year, actually, there can be no new provider taxes or provider assessments to help fund the program. Any assessments that are in place have to decrease the amount that is paid into them over the next 5 years. And so by 2032, our assessments will be down to a limit of 3.5%. That equates to hundreds of millions of dollars a year that we're going to lose in our programs. There'll also be changes in how it is that we can pay providers. Under the new rules, beginning by 2028, we will only be able to pay providers no more than the Medicare rate. So payment arrangements will change as well. We all know that all of that is going to create a huge strain on all of our systems. As we begin to see people who no longer have any type of insurance, as we begin to see rates begin to decrease within the programs. So what I will say to folks is it's never too late to advocate.
Hi, I'm Allison Swiger. I'm a psychiatrist with Penn State Health. And I largely treat people with early psychosis, so adolescents and young adults, and also individuals across the lifespan with schizophrenia. So I see I just want to emphasize how very, very hard any additional administrative burden or times or paperwork or times that people need to renew is going to impact many of our most vulnerable people with serious persistent mental illness who have significant cognitive and organizational impairments as part of their condition. I thank you so much for bringing up the medical exemption form, which I quickly looked up, the PA 1921, which is fortunately quite broad, I think. The question is, does the individual have a mental or physical condition or illness that reduces their ability to work? So that is quite broad, but to sort of go back to Ken's point, I do think that there's a need to educate healthcare providers about some of this language, because as Ken said, you know, we aim to provide recovery-oriented care. Our goal is to get people re-engaged in the community. Some of the people that we treat sort of object to the label of having a disability. And most physicians, most counselors are not really trained on sort of exactly what the different definitions of disability are. So I would just urge and encourage that there be efforts to educate providers as well. We see a lot of forms that all have different requirements and different eligibility. It also, I just wanted to highlight too that the categories of providers who can fill out that form is quite broad too, I think, as you were mentioning. So that includes social workers, mental health counselors. It can be quite broad, so that's a good thing. So those are just sort of some of my comments. I think, I know there were a lot of efforts when the unwinding of the public health emergency occurred. And our office made efforts and the case managers in the area made efforts, and still there were lots and lots of people, particularly those that I treat with psychosis or who young adults who are just trying to survive and sort of figure out how to live and work, who those communications just didn't reach. It's really, really hard. So we will certainly do our best as providers to sort of help spread the word, but you know, people are not going to meet these requirements, and the people who need it the most are the least likely to need it. I'll leave that there. I guess my other question was just about whether MAUD, medical assistance for workers with disabilities, is at all impacted by any of this legislation.
That's a good thing to bring up. That's kind of getting to the point I was mentioning earlier about other categories of eligibility might find their way into. Yes, MAUD is a category of eligibility that's under the Ticket to Work Act, and it's outside of the parameters of these work rules. And I think we expect people to migrate over to the MAUD program if they are eligible for it. The MAUD program has some limitations around age and work. Obviously, it has premium associated with it, but that might be a better place for somebody if it would get them kind of out of the way of these engagement rules. And but because the MAUD program has that premium associated with it, you know, we can't automatically move somebody into that category. And my general recommendation is that, as providers, people we work with, you really have to self-advocate for being placed into that program, because we can't take some categories of eligibility, we can just people into without really doing anything or receiving anything from the law. And on the law side, we really need to have an affirmative, yes, I want to be there.
Before we move on to Ken's question, I just wanted to piggyback off of what Allison was talking about. I think that what you're doing with the toolkit is incredibly helpful. I think for people who are filling out their own applications, this is exactly what needs to happen. But to Allison's point, I think that there's an assumption that social workers, doctors, people who are in the field understand how these forms work and how to define some of these categories. If there could be a toolkit for professionals who are assisting with this, I think there could be a lot of education and a lot of assistance for folks who are doing this paperwork on behalf of somebody else. What is the common thread that we find when we're talking to training entities or people who are doing this work is that this is very complex and very confounding and very confusing. So I think there are probably a lot of things that are missed just because this is not the wheelhouse of people who are doing clinical work. So I'm not trying to put more work on your end, but I think there could be something very helpful if you were to focus on the clinicians who are assisting with this sort of work, because they really do need that assistance. So just something to think about.
Yeah, I think we'll be thinking about that a lot, especially as we build towards what we need to do in 2027. And there are works that do this well today. The Health Access Network has kind of the eligibility assister group. They help on the marketplace side, they help on the general Medicaid eligibility side. I think historically it's been very fragmented by program as well. So we have SNAP outreach partners that exist around the state associated with local food banks and pantries that help people with their eligibility sometimes for the SNAP program. But in Pennsylvania, we're combined eligibility state. You will receive Medicaid and SNAP if that's what you're eligible for and want, and you do it all together at the same office, and that comes with a lot of benefits. And so thinking about ways to kind of like bridge that is definitely on our mind, because it's a shame that the way that the authorities and the funding streams work sometimes keep them running in parallel tracks.
And just a shout out, we have lots of people in this room who would be very interested in helping to assist with that. Lots of community psychiatrists, NASWPAs also here with us today. So lots of people who would be interested in contributing to that process.
I just want to comment that, you know, as somebody who's been in the game for a very long time, I very much remember when Obamacare finally kicked in. I was working in a federally qualified health center where I would say somewhere between a half and a third of people who were coming in were uninsured. Lots of them, obviously I'm a psychiatrist, but it wasn't just that I was. Lots of those folks were folks who had psychiatric challenges precisely because of the issue of maintaining employment. This was during the Great Recession, so they were also the people who tended to get laid off first. Suddenly, all of a sudden, everybody had insurance, you know, and those few who didn't, we were able to take care of. So to go back to a world in which we don't know how many people are going to be covered and then imagine that there are more of them is just really, really shocking. And I think one of the challenges that we're going to have with the safety net is figuring out how we keep up the morale of folks who've been working really hard and actually got to a better place. And now to have the better place taken away is really very, very distressing. And I think that we may need to think about some attention to that, which comes to my a point that I would like to suggest to the state, maybe some of the BIMCOs here and other providers. It may be really useful to find a way to assemble people, particularly parts of the safety net, together regionally, just to start hooking people up together, break down some of these silos, and have conversations about how help people maintain themselves body and soul through processes that we're going through. Maybe to think a little bit differently about how we connect people up together, and take advantage of the opportunities for people to work together. I already, before you guys came, I made it, or maybe you were here when I said it. I really think that we underuse on the behavioral health side, we underuse the primary medical side and don't think about the incredible possibilities of synergy by working much more closely together and addressing the challenges, particularly, you know, I maybe it's a dead horse, but I really think that the federally qualified health centers and community health centers that are out there really are the safety net that on the medical side, on the psychiatric side, we could do a lot more with than we do. So I wanted to just suggest that. And I am also interested in seeing if there's anything we can do in this new world of AI and digital capacity to automize some of the processes that are going to be required on this 6-month basis, or, you know, various other elements. Can we take, we've got some of the greatest minds around these issues, you know, at CMU and other places. Can we tap into some of these resources so that we can help people very easily do what has to be done to be re-enrolled? Is there something that we can do to be kind of out of the box with that? And then lastly, I wonder if we might think about, we have centers of excellence in public service psychiatry that we operate, and we bring fellows in to learn about being public service psychiatrists. I'm wondering if we might establish a relationship, and this goes to you, Jen, and Julie as well. Is there a way we can develop some placements for some of our fellows with you all to get engaged with some of these policy determinations, to be helpful to you, and also to start to open up their minds and ideas about what's possible and necessary at policy level, at the state level, to build some to build their capacity and also to be of use to the state's capacities. So just those qualities there.
I mean, I can speak to the technology side of it because that's what we're working on. Some of the items I described earlier, the document processing tools that we have, the eligibility checker, checking status of notification. We're having those conversations. I mean, the Commonwealth has a robust process to get approval for AI uses. I don't think there's any kind of like blanket prohibition. There's sets of guidelines that we need to follow to ensure that it's legitimate and ethical and functions. But yeah, we see a lot of upside there. Our view, the Health and Human Services Center has a new HIO, or CIO came from CMS, is in my opinion, a technologist. They understand the current state of technology quite well and want to bring those resources to the Commonwealth so that the way that we interact with people can improve. But it's, you know, it's a long process. I can say that routine changes to eligibility systems can take many years, because ultimately we have a combined eligibility system, which, as I said, has many benefits. But one of the challenges is that when everybody's in the line and then everybody has to get a change in because the federal law changed, the state law changed, the governor has decided that the line can get pretty long. And those are the kinds of things we have to work through to get that best possible outcome at the time. I have a good example of this, even the application status check tool, that is only for applications today. It's not available for renewals. I think we have a desire to make that broadly available, but a lot of this is
Carl, I really appreciated when you were talking about shifting people from one category into other ones that are safer. And one of the things I was thinking about was, and I don't know that I like the language on this, but when they talk about medical frailty, it's an umbrella term that would include people on disability, but it doesn't have to. And you were mentioning, I think on one of the slides, waiting for guidance from CMS. do you have any sense right now of sort of like how Pennsylvania is defining that and what, if any, conflicts with the federal government might be there? And if you have any plans for sort of thinking through, can we use the term medical frailty more broadly to make sure people aren't slipping through the cracks, but don't have to go all the way to something like disability?
I mean, there's a lot of layers to how that would work. The first of which is that, while I'm sure we have an interest in what that final outcome is and an idea of what we might want to do, CMS has to lead. They have to be the first ones to say what's acceptable. I think the language in statute says the determination of the HHS secretary or the CMS administrator. Beyond that, that is something we'll have to work out with the clinicians at the department that Deputy Kozak has at her direction and within her unit. I'm on the eligibility side. We don't have clinicians. It's not an area of expertise for us. And then beyond that, the knowledge about that status, it's always, let's say something happens and we get the guidance and clinicians all agree, and if you have some kind of condition, you're medically frail, somebody might tell us that or they might not. The best scenario is that we can learn that information based on stuff we already have, but even that is a technical challenge that we have to work our way through with leadership from clinicians and leadership from technical partners. So it is really a whole effort to get to that place, and it's a pretty long. In truth, we haven't even close.
Yeah, I think the important thing though is that CMS has not issued any guidance on it.
I kind of want to piggyback off what Ken was saying, because as I thought about it, and primary care has been mentioned multiple times, but I see a significant hindrance to our ability to combine psychiatric services with, or a collaborative care model, is the lack of parity in the rates that really the medical field outside of psychiatry is not looking at doing anything with us, because psychiatry rates are so much lower, upwards of 67% lower than a psychiatric visit versus a primary care visit. So when you look at those and partnering with those folks, they're kind of like, well, maybe when the rates get better. So that's a significant hindrance to us. And then the other thing I wanted to mention, I know President Obama's administration was mentioned. I'm going to go back to Clinton, and what I recall when DHS and the services were really being tightened, we saw a huge baby boom. So the exclusions that you see tend to amplify. So therefore, those of us interested in early intervention and gearing up for what's going to come in the future, we really need to kind of look ahead if these things go into supporting those types of services, because they are going to be greatly needed.
I just had a question about the volunteer work and how you verify the volunteer work. If it's because employment, obviously it's employment, things like that, but when verifying volunteer work, are there any standards or forms that need to be filled out by the volunteer agency?
Yeah, there's a couple ways that this can be done. I can't recall the form number, but I would first direct you to /works site, and on the side we actually have a number of critical forms that are included in there. The one that I think we talk about the most is the community service verification form. The way that this document works is that in partnership with a community service provider indicates the frequency and duration of community service that someone is doing, and then indicates that, if anything will change, we'll contact the eligibility office to say that that is the case, and we project forward their continued engagement for 6 months. That's the most beneficial arrangement for the recipient that we can offer. It is certainly beneficial to managing the administrative burden from the Commonwealth. I understand that there are community service entities who really are not willing to structure their volunteering, or structure their volunteering in that way. And there's a separate employment community service verification form, which functions like a weekly document, which is obviously more challenging, but better than nothing if you can't use the other. But both of those items are right available on the backslash work page.
Hi, my name is Barbara Dunn from Children First. And a lot of the Medicaid changes and SNAP changes are not necessarily impacting directly teen and under. But we know that as adults lose coverage, their children also are losing coverage. And we know that the stress in families will go up and will impact kids. I don't really have a request except for the DHS dashboard. And I really love the work that DHS has done and hoping that some of the information that you're talking about for changes will show up on the DHS dashboard and will enable us to see the full impact to children and families. Any more questions?
Carl, thank you so much, Deputy Secretary Kozak. Thank you so much for your time this morning. This has been incredibly helpful. We're going to take a short break as we get our next speaker up on the screen. So I think that's some snacks in the back if you want to help yourself. But thank you again so much for your time this morning. This has been incredibly helpful.
Was there, and we shared her.
Good morning. Can you hear me? Okay, good morning, everyone. Thank you for the opportunity to speak with you today. And I apologize, I couldn't hear the introduction, so I apologize for my delay coming in. But thank you for the opportunity to come to speak today to the Pennsylvania Psychiatric Leadership Council. I am Mike Trobe. I am the Government Relations Officer for the American Psychiatric Association. Just quickly, a little bit about myself. I've been with the APA almost 8 years now as one of the federal lobbyists, and also working on some state legislative strategies as well. So today I wanted to go over some of the state of play in Congress with a look at HR 1 and the remaining healthcare agenda as we move forward in this year. I appreciate a lot of the comments by the previous speakers. I will try not to repeat too much of what was said previously, but also give maybe a little bit of a political lens of some of the issues that we saw through this year and what we see coming as well. So I apologize, I'm going to try to. So just quickly looking at what I'm going to talk about today. First, projecting the 2025 legislative session. Obviously, it's been an extraordinarily active session with a lot of big policy changes. And focus is going to be really on two big pieces. One is the reconciliation and the reconciliation process, and how did we get here with HR 1. Also, something that is not resolved, something that is continuing to play out that is vitally important in the mental health SUD space is also in the appropriations process as well. And I'm going to go over a few issues that are currently in play with that. And then also look at some proactive pieces, some legislative pieces that we are targeting as we move forward in the legislative session this year. And then also just want to touch on the importance of engagement. I think we're seeing this year how important it is to be engaged, not just at the federal level, but at the state level, local level, et cetera. So I wanted to bring up this slide. This is a slide within an internal slide within our department at the American Psychiatric Association. But I wanted to highlight what the importance of advocacy and what constitutes advocacy as well. So I am in that second silo, the federal legislative. So that's mostly where I work. I work with Congress on issues. I'm up on the Hill several times a week when there's not a shutdown. It's been a little different over the last month or so. But for advocacy, it's not just obviously working with Congress at the federal legislative level. And I think with the conference today, you're really demonstrating the need to have that federal-state connection as well, especially as it relates to the changes in HR 1 as they revolve around Medicaid, SNAP, and other pieces too. So at the American Psychiatric Association, we have federal legislative staff that are focused on federal legislative. We also have staff that focus on state legislative and work closely with the APA's district branches. And then we also have staff that is focused on the regulatory and administrative part. And this is going to be important, especially given some of the big changes, because as I'm sure most of you know, Congress passes a law, it's signed in by the president, and then we have a whole process, administrative process. What is HHS going to do when they issue proposed rules around Medicaid? How does that impact the states? Is there discretion with the states to implement different pieces like the work requirements, et cetera? So it was really great to hear our previous speakers talk about that. And I do think I give credit to the organization as you're really stepping in the right direction to make sure that there is that connection to what the feds pass and how the states will be part of that implementation process. And then the last piece I'll mention is the PAC. which is our political action committee, which is also important to make sure that we are educating members of Congress and their staff. So I think it's to understand HR 1 and kind of the state of play we are seeing in Congress, it is important to understand the political power structure that is currently has its hold on Washington. So as we know, the Republicans, we have a Republican administration. We also saw the U.S. Senate flip from Democrat to Republicans. Republicans picked up 4 Senate seats, which gave them a majority in the Senate. And then in the House, we also saw the House, we saw Republicans retain their majority in the House. I would mention, actually, the Democrats netted 1 seat in the election for the House of Representatives, but the Republicans hold on to that majority. So the reason why this is important is because what happened in the election has allowed the party in control to do a reconciliation bill, and where we got HR 1. Because you have a Republican administration and controlling Congress, it allows for the reconciliation process to move forward. And I'm going to talk a little bit about that process and what that means next year, potentially as well. So the other thing we should understand is what happened in December in 2024. This was I think, a pivotal point in Congress that really set the tone for the rest of going into 2025. You had a healthcare package that was part of a larger appropriations bill. It received agreement from what we call the 4 corners. So that means the Speaker of the House, the House Minority Leader, the Senate Majority Leader, and the Senate Minority Leader all agreed on the package. And once you get to that point, in my at least 25 to 30 years working in DC, that was a guarantee that it was going to go through the process and be implemented. There were a lot of provisions, healthcare provisions, that were included in this December package agreement. Extension of telehealth, modifications to the Medicare physician fee schedule where they put more funds into the pie. There was reauthorization for maternal mental health that we were very supportive of, as well as the Support Act, which is a big piece of legislation that promotes programs in the substance use disorder space. That package imploded in December, and it imploded because of a tweet that was sent out, and you saw the whole thing dissolve. And it really left a bad taste, I think, in the mouths of a lot of individuals in Congress, and really it set the tone for the coming for the coming year. And hence, it is not a surprise that I think we're in a shutdown as well, because the appropriation process, there's a lot of mistrust in Congress right now, and we're seeing that move forward now. So what is the reconciliation process? How did we get to this July 4th signing, et cetera? So the reason why we have the reconciliation process is you have one party that is controlling both the Senate, House, and the administration. And the reason that is important is because with reconciliation, you just need a simple majority in the Senate. And usually you would need a 60 vote to stop a filibuster for legislation to move forward. But in the reconciliation process, it allows just a simple majority, and that's when you have big policy changes that could potentially go forward, and that's exactly what we saw as we went through. This reconciliation process is not the appropriation process. I think there was a lot of stakeholders and others that conflated these two processes together. The reconciliation process is different from the appropriation process. The reconciliation focuses on mandatory funding, like Medicare, Medicaid, SNAP, etc. And you can use a reconciliation 3 times a year, unless you're using the 3 triggers in one bill, and that's what we saw. So if you can use reconciliation for spending, also cuts as well as revenue, spending, and debt limits. So all 3 of those were in the latest reconciliation process. They were in the bill, so it was a one-time thing for this year. But that reconciliation process can be used again this year. What we saw in obviously those large changes is we saw Medicaid cuts, and we also saw cuts to the SNAP program, and I think the previous speakers spoke very well on that. The other issue that I would mention there that I think is relevant to this audience is the cap on federal student loans as well. That was part of the process. When this negotiation started, I think there was a lot of focus on the potential for Medicaid to lower FMAPs, especially for those states that expanded the Medicaid under the ACA. There was also a lot on potential block grants going in. We saw there's history of that previously when there were discussions on Medicaid going forward. So I think it's important to take a look at what the assumptions are of the impact itself on HR 1 at a larger scale. We're going to kind of take a step back. These numbers moved a little bit through the process. This process, as I mentioned, started in February, ended in July 4th with the signing of the bill. But it's important, I think, to look at the costs associated as well as the potential impact on coverage. As Congress went through the reconciliation process, right away we knew there was concerns since they were targeting in the House. The Energy and Commerce Committee was tasked with finding about $800 billion worth of cuts in their jurisdiction. Medicaid predominantly makes up the revenue in their jurisdiction. And that's why we knew that they were going to be they had to go after the Medicaid sources. So CBO, the Congressional Budget Office, is a nonpartisan. They provide analysis on different pieces of legislation. And so what does CBO predict will happen over the next 10 years? They're predicting around 7.5 million people will lose health insurance because of the changes in Medicaid. And this will reduce the deficit by $886 billion. So basically, you're seeing $900 billion cut, if you will, over 10 years to the Medicaid program, and it will cost coverage for estimated 7.5 million people. I would say that's also separate from the potential of ACA if the premium tax cuts aren't extended. This is the fight now currently going on, and the reason we have a shutdown. So that number is separate. That's up to about, I think, 4 million people. So you could have an aggregate of 11.5 million, et cetera. So looking at some of the Medicaid specific pieces that and how much they cost, the work requirements is the biggest ticket item. That's $317 billion they see as savings over the next 10 years in the Medicaid program. And as you see, it also makes up the majority of the potential loss of coverage. So this one policy change is obviously very significant, and it really makes up a big portion of not just the costs and the savings, but also the loss of coverage. As you can see, other pieces that are very significant, the provider tax that was mentioned by our last speakers as well, and I can go into a little bit of the provider tax too, but that will generate $182 billion. It's estimated in savings over 10 years. State-directed payments, which was also mentioned, and that's the where the rates are going to be at the Medicare level, so you can't have rates in Medicaid above Medicare. And then the last one is the eligibility determinations. And that's simply moving from every 12 months to every 6 months. And, I think it's an important point that the burden itself is where some of these estimates are coming in, and where you're going to see a lot of people just simply lose coverage, maybe because they can't verify something. They're unable to, keep track of who's eligible and when they're supposed to be signing what, et cetera. So that burden is a real thing, and I think you're going to see a lot of folks lose coverage who may be eligible, but they just simply because of the different rules and stuff. And I think that's why it's so important. With your previous session, you had the state of Pennsylvania really talking about the importance of that. So again, I'm not going to spend too much time going over some of these issues that was covered in the previous session, but workforce requirements, as we noted, was the big issue. That would be 80 hours a month. This goes in, as everyone I'm sure knows, this will go in after the midterm elections, right? So this will start January of 2027. I think probably very intentional that goes in after the midterm. The exemption piece, which there's two pieces where there are exemptions, hopefully broad exemptions for mental health and substance use disorder. The terminology that was used was medically frail for an exemption for the work requirements, and also substance use disorder treatment programs. It will be important to make sure that we, the APA, other organizations at the national level, we are part of a larger group called the Mental Health Liaison Group that represents about 65 different national groups solely focused on mental health and substance use disorder, to ensure that we're all reaching out to HHS to make sure that definition is going to be broad, and make sure we have as many people possible covered under that exemption. And then I think working with the states, your state organizations, your state groups, making sure you're plugged into the Department of HHS within Pennsylvania. And this is going to be important throughout the country for states and advocates to be coordinated in the implementation of these new policy changes, such as the work requirements. So that's one piece. The other big piece, as I mentioned, the provider tax. The provider tax, the first part, which prohibits states from establishing new taxes or increasing ones. Right now, the cap's at 6%. The provider tax is a way for a lot of states to help support the Medicaid program, support the coverage, et cetera. So that starts immediately. And then come October of 2027, states that are above that or at a 6% in expansion states, they are going to have to go down every year by 0.5% until they reach that threshold of 3.5%. So those two pieces, the work requirements, the provider tax, are significant in the cuts that were done to Medicaid, that the potential loss in coverage, as well as how states are financing Medicaid, and you're seeing a shift in costs, and we're really going to probably have 50 different reactions throughout the country to these types of proposals. Another issue I wanted to mention, because there is an exemption as well for mental health and substance use disorder services, as well as primary care services, is for a new $35 copay or sharing of for patients when they go in, which we haven't seen before. So this mandates that states have to have a cost sharing of $35 The good news, I think, for our patients is that the exemptions are for mental health, SUD, and primary care services, but that will be obviously an impact. And this is for not everyone for Medicaid, but it's for those, I believe, in the expansion state. So it's 100% of poverty level to 138% of poverty level would be subject to this $35 copay, if you will, for individual services. The other piece we mentioned, which is a pretty big ticket item, is the state-directed payment, where the rates won't be able to be higher than Medicare. If they are currently in that state, they get reduced by 10% until you reach that 100% level, and that reduction will start in January of 2028. And then, as I mentioned before, the administrative burden, which will start pretty much right away to qualify twice a year instead of the once a year currently in Medicaid. And I think we see a lot of impact there as well. So the SNAP program, I think a lot of this was covered, and your previous speakers also, I think, with their expertise, spoke very well on the SNAP program. Obviously, there's these changes. If you looked at what the CBO, again, going back to Congressional Budget Office, CBO estimated about $186 billion in saving over 10 years, given what was cut from the SNAP program. And the makeup of that $186 billion obviously is embedded with a lot of these different provisions. You'll see a shift of administrative costs go to the states and counties from 50% to 75%. So the feds are lowering their share of the administrative costs there, and also which was talked about was the work requirements. And previously, I believe age 54, they now move up to 64 as well. Also, I wanted to mention, which there was not a lot, I don't think a lot of attention, at least publicly, I didn't see a lot of attention around the cap on student federal loans. It was something we worked with a lot of our colleagues in the not just the physician space, but also the mental health and SUD space. There is now a cap on federal student loans. That cap is $200,000 for professional students, being both the medical and legal. So, for example, going to medical school or law school, you'd be capped at $200,000. There's also a lifetime cap of $257,000 for federal student loans as well. So if you have undergraduate and medical, your cap will be $257,000. Obviously, given the shortages in the workforce shortages, this is a real concern for us, as well as how will this impact students as well. And I think looking at it from an equity lens too, this is going to have a real negative impact there too. So that was really what we saw through the reconciliation process. Again, that reconciliation could come back next year for more policy changes. So it is something that we have to be vigilant about and very focused on. The other big thing going on right now is the appropriation process. So this is a process different from reconciliation. This is a process that is done every year to fund the federal government. There are 12 bills that the Congress has to pass by October 1st to fund the federal government. One of those bills, which we'll focus mostly on, is the labor HHS, because that is a bill that funds SAMHSA, CDC, NIH. So a lot of programs vitally important to you and to the patients you are serving flow through that. So we saw earlier this year, February, March, the president sent his budget request to Congress. When the administration sends their budget request to Congress, it is not law, it is not legislation, but it is a recommendation to Congress on what they think the budget should be for fiscal year 26. We saw really extensive cuts to a lot of the programs important to you all and your patients. For example, in NIH, we saw a cut. The current level of funding was roughly 48 billion, and the administration recommended 29 billion. So about a 40% enormous cut to NIH. We also saw cuts to CDC, cuts to SAMHSA as well. And then there are hundreds of programs that the mental health community follows too. And I'm going to give just an example. There's a program called the Minority Fellowship Program that allots about $20 million to different organizations throughout the country to have a minority fellowship serve in either underserved area to bring culturally competent care. And that program was zeroed out by the administration. That program was also zeroed out in 2018. So we anticipated that happening. But there are many programs like that that we've seen the administration zero out as we move forward. I think the good news is that for the most part, the Senate really restored the cuts that the administration had recommended to Congress to implement. So we saw over in July, we saw the Senate in a bipartisan nature work to restore all those cuts, a lot of the cuts that that were recommended by the president to be restored, including in SAMHSA, NIH, including that individual program, the Minority Fellowship Program, received $18 million. So overall, I really think it was a good response by Congress. It was part of what we felt was strategically needed was to focus on Congress to make sure that our past champions, especially those who have really, we've seen an elevation of funding for mental health and SUD over the last 10 years. And we wanted to go back to those champions to ensure all that work did not go away. So again, we saw a really good bill from the Senate Labor HHS Appropriation Committee. I think what is important to note is the Senate did not provide any funding for the HHS restructuring that the Secretary Kennedy has proposed and the administration also has pushed. On the House side, a little bit more difficult, but overall, I think we're at least optimistic where the House Labor HHS Appropriations Committee landed on their funding too. There were some cuts, but certainly not to the level of where the administration was. And I think SAMHSA is a good example of that. The House provided $1.6 billion above the administration request and nearly $19 billion above the administration for NIH. So these two committees have passed the legislation. However, for the appropriation process, either Congress can reach an agreement or they can pass what is called a continuing resolution, which allows them to continue to deliberate, or the government shuts down. And unfortunately, what we have seen is they did not come to an agreement. And not only did they not come to an agreement, they didn't come to an agreement on a continuing resolution, which would allow them to continue to discuss, and the government would be funded at the current level we are at right now. So they couldn't reach that agreement, and why we're in the shutdown that we currently are in. If you're following this, you probably know a lot of this revolves around the ACA premium tax cuts, with one side, with Democrats asking it to be part of the negotiations to reopen the government, where the Republicans are saying reopen the government first, and then we will talk about the ACA. It has been, we're approaching the longest shutdown ever. I believe Tuesday or Wednesday might be that date. And unfortunately, we have of weeks of impacts, including November 1st with the SNAP program. So not only did you see the cuts in HR 1, but you have a stalemate going on right now on the distribution of those what would be called emergency funds, which just went to the courts. So we're seeing that be played out right now. There were some, I think, signs or glimmer of hope over this weekend. And, from what I've been hearing this morning, that at least there is discussions going on into the Senate. And I really hope over the next week or two that we see progress there and we actually see some of the, we see an agreement and the government is funded for fiscal year 26. So I'm going to skip this and just move on to I think we probably have like 10 more minutes left of the presentation, and I want to make sure there's time for questions too. A couple of issues I just wanted to highlight that the APA has been focused on. One of those is Medicare telehealth flexibilities. Just to provide a little history of telehealth, substance use disorders have always been, since 2018, exempt from the site of service and geographic restrictions that Medicare currently has for many other services. However, telehealth for mental health has not. And we saw Congress pass in 2021 a bill that would try to align mental health with the flexibilities currently allowed for substance use disorder. However, in doing so, they also required a 6-month in-person requirement before you could provide telemental health. It is something we, the mental health SUD community, have opposed. There is bipartisan legislation in both the House and Senate that would remove the 6-month in-person requirement prior to providing telemental health. These bills would permanently move that requirement. Up until October 1st, this requirement has never been implemented because we were able to delay the implementation of this requirement with the Medicare telehealth flexibilities that were part of the appropriations continuing resolution process. But come October 1st, since it was a shutdown, there is now a new requirement in place for the first time for telemental health. Now, that requirement is for new patients only, and it's for Medicare, but is something that is obviously concerning for us. So for Medicare patients, if it's a new patient, you would need an in-person prior to providing any mental health services. So we are hopeful when the government reopens that this requirement will be delayed again. There are also many other services outside mental health and SUD that no longer are allowed to provide Medicare telehealth until the government reopens. Another issue is workforce shortage. There are a number of different policies we have been supportive of. One of those would be expanding the GME for 14,000 slots over 7 years. It is something we have specifically looked at for psychiatry to try to increase those slots. A couple years ago, we were fortunate to able to get 200 GME new slots. 100 of those were dedicated to psychiatry. That actually is supposed to go into effect in 2026. We have not seen a change in slots. We've only seen a change twice in 30 years. So it is something that we are continuing to focus on. And I know there are many other workforce bills out there that others are focused on, including loan repayment bills, etc. So another bill I wanted to bring up that has a lot of bipartisan support and was part of the December package that collapsed is around grants going into states for maternal mortality review committees. This is a piece of legislation that is bipartisan, and we are looking to increase the amount of money contributed to these grants that are going into states for maternal mental health. Current funding is at 58 million. The current legislation we're supporting would move that up to $100 million a year, and that would reauthorize it for 5 years. So this is something we have been focused on, and most of these bills, as you can see, are bipartisan, have bipartisan support. But in the current environment right now, with the shutdown, you are not having hearings, you are not having markups, and it really is impacting not only just the funding aspect, but any progress in other healthcare spaces to move legislation forward. Another piece of legislation that is bipartisan that we've been working on is the Complete Care Act, which integrates behavioral health into primary care. It incentivizes primary care to adopt different integration models. The model for the APA that we have been focused on is the collaborative care model. Because of some of the issues with implementation, some of the upfront costs, some of the reimbursement, et cetera, there is legislation that is in Congress now that would provide for an increase in the CPT codes for the collaborative care model for 3 consecutive years. The first year, it would be 175% of the current Medicare reimbursement. Second year, 150%, and third year, 125%. So this is legislation that actually passed the Senate Finance Committee last year, but stalled in the House. So it is a piece of legislation that has some traction, I think, that could potentially move in a healthcare package. But again, with the shutdown right now, it's difficult because we're not seeing any legislation move through the process. And for at least a little bit of good news, we did see the reauthorization of the Support Act pass. And these are grants or programs for the prevention, treatment, and recovery of substance use disorder, first implemented in 2018, I believe. And the reauthorization is for 5 years. This did pass in a bipartisan manner, both the House and Senate. You know, one of the programs in the Support Act that we have really have advocated for is the STAR Loan Repayment Program, which was provided $50 million annually to provide to clinicians who wanted to go or serve in high opioid areas or mental health shortage areas. It would be a 6-year service and provide up to $250,000 in loan repayment. And this is a program that we have been very supportive of. And then I just wanted to touch on, because certainly given this year, we really are in the need for engagement. It is not a pretty process. Certainly it is not a pretty process, but it is a process that we need to be part of. Stakeholders need to be part of, and it is something that we've been pushing within the APA, which is also called the constant advocate. It can't be a one-time advocacy, and you can't just think you're going to do advocacy when there's a crisis. We really need to, I think, as a community, be more involved in establishing relationships, and that's establishing relationships with folks that maybe we don't agree with 100% of the time, and maybe we don't even agree with 50% of the time. But it's really important that we develop those relationships, and maybe we serve on healthcare committees for members of Congress, et cetera, or we establish a relationship with staff or district offices, et cetera. It's not easy, and I know everyone has a full-time job, and this is something that is not easy to do, but I think vitally important. I also like to provide statistics to at least try to highlight the importance of, what we see in Congress and the reason why we have to kind of cut through the noise of Congress. In the 118th Congress, there were over 19,000 bills introduced and only 274 of them passed. Now, that's a little bit misleading. I say that because some of the packages we're seeing over the last couple of years are larger packages, so not as many individual bills move. But I think the point being, it's obviously a very small percentage of bills that actually gets done. We had nearly 2,500 healthcare bills alone introduced in Congress, and 400 of those were focused on mental health and SUD. So as you can see, there is a lot going on, and we really do have to cut through the noise and stay focused on our agenda, etc. Something that we as an organization also are pushing is just to make sure people are involved, not just at the federal legislative level, but at the state level, as you saw, especially with your previous speakers. It's so vitally important to have that coordination and that connection, and to also be involved, recognizing that connection between the federal, what the feds are doing, and how it impacts the states. I mean, it's highlighted very much this year, given what HR 1 has done. Also responding to alerts when they go out. We are strategic when we send out action alerts. Action alerts go out to our members to write into their members of Congress. I get a lot of questions. Do these work? Do they make a difference? Yes, they do. I worked on the Hill. They make a difference. It's not overlooked, etc. And also trying to get others involved, and sending those alerts out to other members in the organization. And the last thing I would say is contribute to the PAC as well. I think that's an important piece to educate members of Congress and their staff on issues that are important. We recently just had our federal fly-in 2-day conference, had 164 psychiatrists come in, representing 46 different states, and we had nearly 200 meetings, and we focused on a lot of different issues, but I think it's really an important piece. So I'm going to stop there, and I will also stop sharing the slides as well.
Challenging. There we go. Now we're echoing.
Okay.
Good now. Thanks very much. Questions? There's been a lot to There you go. Okay. Still echoing. There's a question in the chat. What hat should we contribute to?
Thank you for the question. I mean, it's a PAC I think your organization has. Obviously, for APA, it would be the APA PAC, but I think any relevant PAC that you're associated with, a lot of the organizations have these individual PACs. Hi, I'm gonna, hopefully you all can hear me, so I'm gonna answer the question, not through the chat, but verbally. Yes, so there is, okay, great. Thank you for letting me know. Yeah, so the APA is advocating for two pieces. One is the current funding for SAMHSA, but also in opposition to restructuring SAMHSA itself, where you would lose so much of what has been built within that department if you combine that with HRSA. So it's a good question. It is something that we have been focused on, and I would say the larger community, the mental health liaison group, I actually had a meeting this morning with that group, and we are looking at some more advocacy work around the RIFs themselves, the potential RIFs within SAMHSA, because you're seeing huge cuts to the department itself. So I think there's two big issues to focus on: the restructuring that will lead to cuts in SAMHSA, but also what happens to those programs as well in SAMHSA. I think Rosemary Dempsey, not legislatively, we haven't been as focused on the dish payments, but certainly if there are groups that are taking the lead on that and the APA can be helpful, it's something we certainly would work on or would be willing to work on. So there's a couple, someone asked in the chat about the workforce legislation being supported. So there's a number of different pieces of legislation. As I mentioned in the presentation, graduate medical education slots, that is something that we're working a lot within the physician community to ensure that we have an increase in slots that we really have not seen over 30 years. Also, the loan repayment piece, I think, is an important piece that we'll continue to focus on to make sure it is funding. That's the STAR loan repayment, where clinicians can dedicate services into high opioid areas, mental health shortage areas, et cetera, with repayment up to $250,000. There's also the Conrad 30 bill that we've been pushing as well. This allows an exemption for the J1 visas. It allows clinicians to stay in the country, into the practice they are at. Each state gets 30 applicants to be able to support through this Conrad 30 program. It's a program we're trying to get reauthorized as well. And I think hopefully I answered that question. I know it's a broad question on workforce. I think there's a number of different workforce questions as well. Okay, thanks. Thank you.
Can you hear me now? It's less echo.
It's still gonna go.
Yeah. We have at least one more question coming through.
I don't, I apologize. We talked about the 1115 waivers. Someone asked about, which would be a little. Yes, 1115. So in regard with the 1115 waivers, I think the impact you'll see, and I apologize, I don't mean to be vague about this, but those policy changes, as you saw, right, there were 2 states, I think previously that had 1115 waivers around the workforce requirements. So you are going to see changes in that space from the HR 1. So they will impact some of the waivers that you're able to do or a state is able to do, given all these new policy changes that just have come into to CMS. Does the APA have a nuclear option? Not quite sure what that question means. So I'll let whoever asked the question maybe explain a little bit more about that.
I'm not sure if I can be heard, but are you able to hear me? Yeah, I'm joking a little bit about the nuclear option, but like a big kind of last resort kind of major system impact that you could kind of implement, or is it just going to be steady kind of boots on the grounds, keep what you're doing, keep the pressure on?
I think it's a good question. I look at the appropriation process as a good example of why we need to continue to have a advocacy push with Congress. Even with everything going on with the administration, and I know it is very easy, and it's easy for us as lobbyists to get sidetracked on different issues. There are so many things that come out every day, etc. But I personally and professionally believe that we really need to continue to focus on Congress, because what Congress did, notwithstanding the shutdown, what Congress did is really pushed back on the administration on those cuts and those recommendations. So I think strategically, it is really important for us to continue to build those relationships with members of Congress, speak out to them about when things come up that are important to you all, to raise those issues. And I think there's so much that's part of that appropriations process, and there's so much funded and embedded in there for so many programs, hundreds of programs that patients benefit from throughout the country. I think it's where we need to continue to fight in that space and utilize our congressional champions to make sure there is adequate funding for those programs.
Thank you.
Absolutely.
Mike, I think we're gonna put closure, and thank you very much. Thanks everybody for the questions.
Thank you.
All right, so for people online, just to give you a heads up, we're having a bit of a delay here live. Representative Schlossberg, it's very nice to see you. Hello. So I'm going to give a few instructions on how we're going to handle the Q&A portion, and then we'll open up your mic and we'll get started. So for those of you who are here in person, when Rep. Schlossberg is done presenting, we're going to have you walk out into the hallway if you have a question with Lucy, and she will have you ask your question for the computer out there. For people online, if you would like to speak online, that should be fine. You would have no issues. I would suggest raising your hand perhaps so that there could be more organization to the questions, but that's how we're going to handle the Q&A portion. So does that sound like a plan to everybody? Okay. Very good. All right, so Representative Schlossberg, thank you so much for being here. We know you're very busy right now, hopefully good busy. You're here today to talk a little bit about the Mental Health Procedures Act, which we started the conversation last year, I believe. But I know that this is something that continues to be on your mind, so we're eager to hear once budget is passed, if this is a priority for you, and anything that you want to update us on in general, but particularly the Mental Health Procedures Act. We're looking forward to hearing about what your thoughts are. So welcome and thank you.
Thank you very much. Okay, good to go? Thank you. I was worried about that because I'm thinking to myself, I'm going to start hearing an echo, and that sounds horrifying. One of me is more than enough. It is very much to be with you all. Thank you very much for being accommodating. I was planning on being there in person, and we've actually got a series of meetings that have popped up. If you've been following the news at all, you know there have been quite a few five-party meetings between the governor and all four caucuses in the legislature, leading to a sense of cautious optimism. I hope that we will be through with the budget shortly. I'm going to just knock on some wood here. So that is certainly the my hope, and we'll see how the next week or so brings. That being said, I do want to take the opportunity to say thank you. I know I've actually spoken with many of you who are either in the room or online in the past about some of the things that we're working on when it comes to the Mental Health Procedures Act. I believe when we spoke last year, we were still very much in the beginning stages. And let me sort of lay out where we've been, where we're at, and where I hope to go. So I don't think I need to tell anybody in this room that the Mental Health Procedures Act of, I believe, 1968 is woefully out of date. It was built for a mental health system that no longer exists, that was far more robust, with far less interaction with law enforcement, crossing county lines, and more. The issues that need to be addressed with an update to the Mental Health Procedures Act are multifaceted. And what we have done over the course of the past year is meet with stakeholders, and a lot of stakeholders. We've probably held somewhere in the area of 30 meetings with consumer groups, doctors, law enforcement, hospitals, county, and more. That has given us the opportunity to get a better sense of where the Mental Health Procedures Act is and what we can do with it. As many of you may have seen, we put together, I think, a pretty comprehensive document, a feedback report that laid out some of the problems with the Mental Health Procedures Act. I think you can broadly, very, very broadly, divide those problems into two large segments. And this is, again, just specifically with the Act. The first is the technicality of the Act, the who can do what, when, and how. So that deals with how different counties handle timing, how different counties and hospitals and jurisdictions handle timing, enforcement of the Act, who can do what, and when clocks actually start. That's one of the things that we heard pretty uniformly. We also know that there's a lot of difference between how different counties enforce and interpret the Act. We also know that there's a lot of differences between how hospitals enforce and interpret the Act. That really gave rise to what I think is a real need to clarify some of the circumstances to make sure that the Act can operate in the most effective and efficient way possible. The second change, and arguably the more important one in my mind, is that of scope. The Mental Health Procedures Act is one of the few areas in law that I have seen, and also frankly in healthcare, where you have to absolutely wait until the last possible moment before the Act can actually be executed. One of the real frustrations I've had in talking about the Act with both consumers, family members, law enforcement, and hospitals is that The act is relatively narrow, meaning that somebody has to be the standard is a clear and present danger, which means that they not only have to be making threats of violence, but have to have taken some sort of action in order to move forward with a violent act in order for 302 to be executed. That, unfortunately, has led to tragedies. And frankly, there's no greater public example in Pennsylvania or really in the United States than with the recent attempted assassination of the governor, where the perpetrator of the arson the family of the perpetrator of the arson attempted to execute a 302 on him. But because police could not find any movement towards an active threat, they were unable to execute the 302. And as a result, the individual in question set fire to the governor's mansion, almost caused a massive tragedy. Where we would like to take the Mental Health Procedures Act is in the same direction that other states, like I believe Minnesota and Arizona, have taken it, where you can create an act that sets a standard for predictable psychological deterioration, meaning that you can take into account a variety of factors, including past threats, past history of psychological deterioration, and more, in order to potentially execute a 302. Now, you still have to balance it because there will be concerns, and they are completely appropriate concerns, about overuse and abuse of the 302 system. That's obviously an unacceptable outcome as well. What I do think, though, is that the 302 doesn't do a good enough job of getting somebody the help they need at the moment that they need it. You shouldn't have to wait until the last possible moment before somebody enters a crisis and a 302 actually applies. We should have an act that's robust enough to be able to execute a 302 in the event that somebody is clearly going to shortly be a danger to themselves or others. And that's an area where I'd like to see the 302 updated as well. So where are we? Well, we're in the stages of putting together draft legislation. We had one hearing in the House Judiciary Committee that featured medical professionals and judges. It was really, really insightful for the actual operation of the 302. It was a Judiciary Committee hearing. There was positive feedback from both Democrats and Republicans. And in the political environment that is Harrisburg, you need positive feedback from both Democrats and Republicans. My hope is that I'll be able to identify a partner in the state Senate. We've had some preliminary conversations with a couple of senators. I don't really want to get into the details yet, but there's a clear recognition that the 302 needs to be updated to better reflect our current mental health system. Once the budget is done, I plan on bringing this to the attention of the rest of my leadership team. It's actually something that's been brought up time and time again. So I think there will be a real interest in visiting the Mental Health Procedures Act. I want to go forward only once I've also identified a Republican senator to carry the ball in the Senate. We know in Pennsylvania, big bills don't move without bipartisan buy-in. And if I can find that senator, I think will dramatically enhance the chances of actually passing this legislation and hopefully doing some good work. So that's, in a nutshell, my plan. I am more than happy to take any questions. I'm sure there are quite a few. Yep, if for folks who are online, I can certainly just read the questions if that's easier. So, and for those of you who are in person, whatever works. I can't see or hear anything right now, which I'm sure is by design, as long as you folks can see or hear me. Debatable. Thank you very much. Until those hallway questions come,
can you hear me?
I sure can.
Okay, so I'm coming to you from the hallway. So if there are folks inside who would like to have a question for Representative Schlossberg, please step outside and we can ask those questions and folks can hear them.
Until then, I just stare awkwardly at the camera. Keep in mind, I'm on my porch right now by myself. If you hear barking, it's my dogs.
Oh, great. All right. Lloyd Wirtz is here and he has a question.
Hi, Lloyd.
Hey, Mike. I'm so glad to see you here. Too bad you couldn't be here in person. Mike, we're hearing about your inspection of the Mental Health Procedures Act, which is a good one. 86, by the way, I think was the last revision, or maybe 88 for that act. It didn't go actually back to the 60s, but it was nonetheless not a short time ago.
Right.
Nonetheless, there's another discussion about amending the 302 Act, the Mental Health Procedures Act, to include folks who suffer primarily from substance use disorders.
Yep.
Now, this is of grave concern because having worked in that system, having run county programs, having worked in inpatient units, the current treatment facilities for folks with substance use disorders are not locked.
Yeah.
And it would be very difficult for me to understand how we could proceed with an involuntary commitment, other than a court-ordered commitment. That's different because you leave and now you go to jail. But an involuntary commitment for someone who has a substance use disorder with our current system of service availability. How do you see what you're doing with an inspection of the act in the same context as that is proposed to include substance use disorders? Thank you.
And Candid, I appreciate you bringing that up because I am familiar. That's an effort largely spurred by Philadelphia, and I believe the mayor, Senator Street, and there was a Republican I'm missing, but I can tell you that those two efforts are completely separate. I'm not working with it, nothing against them. Certainly, I'm just not working with those senators on that effort. I will tell you that this is certainly something that came up, and it's not something that I support, and certainly not something that I support as part of the efforts to revise the Mental Health Procedures Act that we've done. There are some places that do it. Places like Florida has what they call the Marchman Act, where they can actually involuntarily commit somebody for substance use and abuse. It's not something that I support as part of these efforts for a variety of reasons. The first is just simply the data. I question whether or not it would actually be effective. I certainly question the expense associated with that because, as you just correctly said, Lloyd, our system is not built to involuntarily commit somebody for substance abuse. It is for mental health, but substance abuse is different. And while there's overlap, you'd have to create an entirely new system that we don't have the capacity or the investment for. And the second, candidly, is political. Politics is involved in everything. Expansion of that would run into immediate opposition from a variety of sectors, and I have no plans on kicking up a hornet's nest for something that, from a policy perspective, I don't support. I think this is going to be difficult enough because there are absolutely going to be people who are deeply passionate about the idea of expanding involuntary commitment. I get those objections completely. I think it's something we need to do.
Hey, Mike, this is Deb. How are you?
Hi, Deb. I'm good. How you doing?
Good. I had a question and then a comment. When I worked at the Psych Society, I know one of the biggest things, and when we also worked with OMHSAS, is that there were questions not necessarily about changing the law per se, but having education or training that makes it standardized across counties, because the problem has what used to be, see, counties and other people, mental health review officers, they all interpret it differently. Like you were talking about the clock and you were talking about all these other things. So I don't know, is there a way, I don't know if you can make it in statute, but is there a way to kind of more standardize what the procedures are before opening up an act? And the reason is because open up the act, you know how it is, everything gets thrown in there, but the kitchen sink people who want to do a bunch of things where, you know, and even if you say I want it to be a limited basis, everybody comes after wanting to do more things to it. And you know, so that was the one part of it. And then the other part is just as now more representing as a family member versus, since I'm not the Psych Society, is when you said you spoke with families, like who did you talk to, or is there a way for families to be included when you're at the table? Because a lot of times we don't always get included in the conversations, but we're really the people who it's impacted the most, and including, you know, brothers, sisters, all that kind of stuff.
Yeah. From a family perspective, the conversation we had were folks that were brought to us by groups like NAMI, who said, hey, we'd love you to have a conversation with these folks. They might be able to provide you with some really interesting insight. And we've gone through groups like that to try to reach out to consumers and family members as well. From a standardization perspective, we want to make sure that we give, there's a weird balance here because you want to make sure that you give counties the opportunity to create systems that work for them, but at the same time, the lack of uniformity is really creating problems, especially when you have a situation where somebody lives in one county but has a 302 executed against them in a different county. The way we're trying to thread that needle is by coming up with some better definitions for certain acts, so that things that really shouldn't be, that should be standardized, like timing questions, you should really standardize when clocks start running for legal reasons. So that if we can better define when the clock runs, and you do need to open, you might be able to do that bureaucratically, but I think it's better in the bill itself. If you can better define those questions, you can create an enhanced uniformity. I know what you mean about concerns about opening up the act, but there's a lot of things I think we have to open up the act for, including, as I said, the most important thing I really am coming at from this is looking at expanding the circumstances in which a 302 can be executed. I really think that we have the evidence to show that that works, the evidence to show that we're doing it right, and the ability to do so, and you got to open up the act for that. So that's definitely something we're looking to do right now.
Hi, Mike, it's Ken Thompson. How are
Hey,
you?
Ken.
Listen, thank you for taking the time, and also just thank you for all the effort you're making there to slog out through this session and to keep the mental health stuff in mind. We really appreciate it.
Absolutely.
I have two things that I want to raise. The first is, are you imagining that one of the ways that the 302 might be operationalized in this expanded definition of people who are eligible for it to include the possibility of AOT? That we would be not necessarily thinking of having people have to go into hospital, but that we would be looking at some other mechanism of keeping an eye on assertively what's happening with them. That's the first question. Second question is, there's been some substantial work done in Allegheny County looking at the impact of 302s on people's lives. And one of the key things that we found is that people, whether or not the 302 is actually operationalized or not, what we've found is that folks who are 302'd or brought to consideration for a 302, that there is a very high rate of mortality within the 5 years that follow. Up to 20% of people are dead in 5 years, which is exceedingly high. And I'm wondering if one of the other aspects of the legislation might be some way to, one, monitor the impact of 302s and what happens to people after 302s. And the big thing that they found so far is that people get 302'd and then they are lost to service after they're discharged. And part of the concern is that there's limited capacity to reestablish trust with people around service provision after 302s have been exercised. So I'm wondering if we might at least study 302s and the impact it has on people, and then also think about sort of preemptively, as you're suggesting, think about ways that we can work to continue to engage people following the 302 in terms of helpful and useful services. So
I had heard those numbers, but that's a really interesting way of looking at it. What sort of monitoring we could do afterwards. I don't have any, that hasn't hit me yet, but I will pass that along at a bare minimum to do some data collection. I would also like to see, and again, I have to double check where we're at with this. I don't know what sort of warm handoff provisions are in there. Like, what can you do to ensure that somebody does continue service, or does somebody after 302 is executed get case management services? Something like that might be particularly useful as well. Obviously, there would be monetary and capacity questions, but that would definitely be worth exploring, and maybe you could ameliorate some of those concerns.
Herb Schlossberg, this is James Fairfax Colombo. I'm a clinical forensic psychologist from Philadelphia. I had just a couple questions. One was a context question, just to see if, I just wanted to get your insight. We have seen movement in some areas of the Mental Health Procedures Act. So I'm thinking specifically about, and we talked about it earlier, aligning it with HIPAA, and some of the information sharing procedures. So my first question is sort of, why do you think we've gotten traction in some areas, particularly adding new things in? And even what Lloyd was mentioning about, are we adding it in so that like an overdose qualifies as a, so why do you think we see traction or movement in those areas, but not revision, when everybody seems to agree that there are some issues?
I think the smaller areas, and I will use, the best I can offer is my own experience with this. The smaller areas, because there have been minor improvements. The last time the Mental Health Procedures Act was completely opened up was around a decade ago, when Representative Tom Mert spearheaded the addition of AOT into it. Something that I think Chester County is the only one that has up and running, but Allegheny is working on as well, because it was a relatively minor addition. When you got right down to it, it just added something. It didn't cost the state any additional money. It just gave the counties additional dollars. Some of the HIPAA alignment stuff, again, that's the same thing. It's a relatively slight addition. What I'm talking about really is a wholesale revision, to one of the core facets of the Mental Health Procedures Act. And it's taken over a year of work before we can even get to a point where we're close to getting a draft legislation. I think, and I do not mean this to make myself sound like the greatest guy on the face of the planet. It's just an area that I've cared about and where I've put a lot of time and focus, and where I'd like to pretend I'm dangerous enough to know what I'm talking about a little bit. I think that you just haven't seen a ton of that, and that you've seen legislators, and again, you said with no shade whatsoever, people have different priorities. And this is just one of those things that kept getting kicked to me in particular. And it's also the complexity of the issue is added by the fact that it touches so many different people. So to be perfectly honest, the first time the Mental Health Procedures Act and the real out of date nature of it really hit me wasn't even a conversation with, I don't think, anybody in the room. It was a conversation with law enforcement who was talking about how difficult it is to execute a 302 on somebody when they know that person is going to wind up harming themselves or harming somebody else, but they, because of the specific criteria, they couldn't get it done. And now looking at other states and finding out the ways that other states have been able to expand, to safely expand 302 criteria, that kind of pushed me in that direction. The fact that this touches so many different sectors of healthcare, law, and local government makes this particularly complex. And I'm really, really curious to see what happens when we actually do finally launch the legislation.
Thank you. And I had well, just one more question. And I think you actually did a really nice segue into it, talking about law enforcement. So I'm a clinical forensic psychologist. And so my main interaction is in the 400 section. But the 400 section links back to the 300 section. And I think a lot of times people don't necessarily realize that. And one of the things I've been thinking about, particularly with information sharing, is there any way, or when you're thinking, like, one, do you have anything in mind for how you would like to revise the 400 section? But my other question with that is there a way to make it more conducive for things like diversion? So when I'm thinking about like the police, deflection is getting really big. I'm a big proponent of sequential intercept model, but you run into some issues when you're trying to share outside the behavioral health system. So can you talk a little bit about what you might want to do for the 400 section?
We had, and let me bring up some of my notes here before I open my mouth. That came up pretty extensively for obvious reasons. The challenge is that competency restoration is so difficult in and of itself. I don't know if we necessarily were going to tackle it broadly. I know that this issue did come up repeatedly, and there were a lot of questions about what can we do to try to modernize the system and bring it better into line with some state or U.S. Supreme Court rulings that would better allow for competency restoration. But to be honest, I'm more on this particular effort. I'm concentrating more on the 302 section than the 300 section rather than the 400 section.
Thank you.
Yeah, of course. Thank you.
Okay, I will ask if there are any more folks who are inside who would like to come out into the hallway and ask any questions of Representative Schlossberg. But this is also a great time for if there's anybody online who might have a question.
It's Rosemary. I'd love to ask a question, make a statement, if that's okay.
Sure.
Hi, I'm Rosemary Dempsey. It sounds like you're very familiar with other people here. I'm not.
It's okay.
I'm from Allegheny County. I work for DHS. I'm also a family member and advocate. I wanted to let you know that Allegheny County is in the middle of working on a mobile competency restoration team, and it's going exceptionally well. It's starting in the jail, and there are about 19 people being served in the community. And it's been very successful so far. The goal is to flip it to health choices. But one of the problems is to find a reimbursement model that pays for the science, right? Which is really cognitive remediation. And to pay for science is difficult because insurance, I worked at community care for 25 years. Insurance pays for events, right? Inpatient, outpatient, right? Therapy, group therapy, family therapy. And to pay for the science, there's the way to do it. And one of them is supplement in lieu of service. And I'd advocate that even though there's a cap on that, we'd be able to do that. And we have a ton of support from the judicial, I don't know how to say it, all the different courts across
the courts. I got you.
Yeah, several different places. So I just want to put a plug in to advocate for your support in the creation of some supplemental service to be able to pay for that service and get it statewide.
That's wonderful. And I have to tell you, you folks in Allegheny County have really done an excellent job. I met with, and I cannot remember the woman's name, but she provided some feedback on what we're doing as well. She might be responsible for your mental health system. But who was it?
Aaron Dalton.
That was it. Yes, thank you.
Yeah.
You folks have really done a lot in
Yeah.
Allegheny County. And the efforts are appreciated. And I'm not wrong when I say you're looking at creating an AOT system where you have
We
all
are. No, yeah, actually we are, definitely. Yeah. Right. And the other thing I wanted to point out is they've done extensive research on 302s. And one of the things that I found most helpful, there's an Allegheny Analytics website that shares the research. One of the things I found most interesting about the research is that they learned that when doctors allow the 302 to be overturned to a 201, that the engagement is and the outcomes are improved. That element of self-determination,
Yep.
just being able to say you can come in voluntarily instead of voluntary is the first choice, and it has made a big difference. I think that's so recovery oriented. Don't know where that fits in, but wanted to share it with you and want to say as a person, family member, I really appreciate the work you're doing.
So it's funny that, thank you. It's funny that you say that, because what you just said, I've gotten pushback from both hospitals and law enforcement, people converting a 302 to a 201 and then discharging before maybe they would have been allowed to under a 302. Clearly, I get it. I just don't know, again, how you thread that needle. Because there's people, if you make that conversion and then discharge and somebody's still potentially a danger to themselves or others, you have a problem. But we want people to be in charge of their recovery at all times, whenever possible. So I don't know what the answer is, but I can tell you that what you just mentioned has been specifically pushed back against by certain stakeholders.
Yeah.
But what you just said, I get you. That's
yeah.
I just don't know the answer.
Well, we have the data to prove it, and I think the psychiatrist in the room would tell you about how to convince people that self-determination and engagement and some therapeutic trust and is building is key. Thank you.
No, and thank you for mentioning that. Because that's last people that spoke to me about the problems with that were actually law enforcement. So I appreciate the other perspective.
I'm sure Aaron will be willing and desire to have a conversation with you.
That's something we got to go back to. All right.
Thanks, Rosemary. Rosemary, is it okay if we share the resource you put in the link or in the chat?
Of course.
Great, thank you. All right, we have one more question here.
Hi, Mike. This is Allison Swigert. I'm a psychiatrist in the Harrisburg area with Penn State Health. And I think many of us in the room aren't very familiar with the civil commitment criteria in Arizona and Minnesota. And I know you talked about sort of increasing the scope of who might be captured by it. But for those of us who aren't familiar, could you expand a little on what about those states' legislation is appealing to add in here?
Yep. I am frantically there it is. There is, and I do not have it. Oh, wait, maybe this is it. Yep. I will actually put the link in the chat right now. There is a report that was put out by a group called the Treatment Advocacy Center that lays out best practices for involuntary commitments. One of the things that this group noted was that states that can create a system that allow for somebody to have a 302 executed against them in the event that there is a clear, predictable psychological deterioration, which basically lays out criteria in which somebody is decompensating, they're a danger to themselves and others, but it is a less imminent danger than our current standard, which is clear and present danger. Under our system right now, somebody has to be a threat to themselves or others and have acted towards that threat. So saying, I want to hurt myself might not necessarily be enough to get a 302, but I want to hurt myself and get a gun might be, or would be. This would allow for other factors to be determined when executing that 302. I'm not sure the specifics off the top of my head, to be perfectly honest, but that is how it would achieve that goal. That's how it would expand the criteria for a 302 to be executed.
Thank you for that explanation. One additional thing I'll add that is a source of I think frustration for psychiatrists within the current act is that In terms of the timeline piece, like you're talking about being only able to go back a 30-day period is
Yep.
very limiting. And I think maybe part of what you're suggesting with some of these other states and how they're putting things together is also being able to make the case that someone's showing sort of a pattern of similar deterioration that led to a historical, longer than 30 days ago, danger or event. And I know that is a real limitation when I've given testimony in hearings because we think about previous risk as being a big predictor of future risk.
Yep.
Just urging consideration of that too.
And I can absolutely tell you that that 30-day look back has come up repeatedly as being far too limiting. And I definitely agree.
Thank you.
Thank you.
Hi, my name is Ralph Kabakoff. I'm the Vice President of the Pennsylvania Clubhouse Coalition. I appreciate your work on the mental health, with the mental health community. And I just wanted to ask what thought, and I don't have the solutions for this, but what thought has been put into making sure people aren't involuntarily committed when they don't need to be? It seems like, unfortunately, there's been a lot of move in this country to move the homeless people out of communities and put them into you know, well, you got the question. Do you have any ideas about how you can change the laws to make sure that they're also protected when they don't need to be inpatient?
I think, again, there's a difficult balancing act here. And I think that if you can write it narrowly enough where only actual symptoms or behavior are written in, as opposed to, let's say, lifestyle choices or economic circumstances, I think writing something like that would be that explicit would make it easier. You know, for example, the president issued, if I'm not mistaken, he issued an executive order close to the beginning of his term that basically said they wanted to criminalize homelessness and put people who are homeless into mental institutions. No, that's not the purpose of the 302 by any stretch of the imagination. And especially given the environment that we're in, I think some really clear guidelines about not only what does qualify for consideration, but what does not would be really, really important.
Thank you.
Thank you.
And this is James again from Philadelphia, and I just wanted, in line with the conversation about things being recovery oriented, one of the things I wanted to sort of just flag on the radar that maybe would be a helpful thing to address specifically in the Mental Health Procedures Act is like a psychiatric advance directive or a mental health advance directive. So when I used to work at the inpatient hospitals, we would, and what you were mentioning about 302s, you do see from a practical effect, once somebody is in the hospital, the standard kind of changes from when somebody's going to discharge. Like, and I think about particularly like an insanity acquittee or something like that. You have a much higher standard for discharge, and I don't know that this should be the case, but like what you see practically happen is it's harder to get into the hospital. It's harder to get into the hospital, but it's also harder to get out of the hospital.
Right.
And one of the things I often thought when somebody was stabilized was, why don't we have them do a psychiatric advance directive right now so that the next time something like this happens, we can go straight to the thing that they want to do. And I think the thing that usually gets in the way, my understanding, probably in Pennsylvania, but in all the states, is there's not like a centralized infrastructure statewide to be able to effectuate that in a way that like makes sense. And so you see every county have a version of this. But it can be, and you were mentioning earlier about like, well, what if somebody's in this county and there are 302s in another county? So it's just something I'd put on the radar of if we're trying to be really recovery oriented, if we could actually find a way in Pennsylvania to be the standard bearer for that, that would be a very big feather in the cap of Pennsylvania.
Yeah. It's funny because this was explicitly in an email that I sent to my staff a couple of weeks ago that I wanted to make sure that we did something to try to promote these. And what you just said is completely correct. It'll make life a lot easier if we can get people stable, who are stable, to execute. So, you know, it's basically a living psychological will if you do it right. And that could be really helpful in making future medical determinations. So yeah, I agree completely. I don't know what the answer is. I do know it's worth checking into though.
Thank you very much.
Thank you.
Well, Mike, you've stuck around long enough to get a return from me. So
Bye.
I apologize, but I have we've been having a brief kibitz on the side while you've been speaking about what are some alternatives to hospitalization that might come up in a 302. And we mentioned, as I mentioned before, the AOT. I did want to just briefly describe another example of a intervention that's been used elsewhere that may be of some kind of interest to think about. In Scotland, for example, one of the things that they'll do is if they have somebody who's deteriorating, who people are worried about and are beginning to edge towards thinking they need a 302 or similar, what they've done is they've had a judge assign a peer support worker to work with that individual to address any particular challenges that they're facing. And then they are brought up for review every week or two to see how things have progressed as a way to avoid hospitalization, but also to ensure that people are attended to, and to do it from a perspective that is not immediately, goes to the medical side necessarily.
Right.
Involves peers. So I want to just mention that as one of the things that you are opening up here, and this may be the concern that Deb was raising, maybe there are ways that we can respond to people that are different than the ways that we have generally thought about in the past.
Right. I am not familiar with anything like that they've done in Scotland, but happy to take a look. Absolutely.
Hey, Mike, this is Deb again. I'll go on a field trip with you to Scotland if we have to.
It's going to be tough. Yeah.
Okay. I kind of on the line of what Ken was, because we were talking about it, because of course you have to go in the hall and then come back out of the hall or whatever.
Right.
But has there been any, and I know funding is always a big problem, but I mean, like funding things like, again, to crisis, like funding more crisis in the crisis and diversion and things like that, because my biggest concern, I'm sure you hear about it, and I mean I have it from a personal experience because I have a daughter who is a survivor, and anytime she starts to spiral, I'll say, do we need to call crisis? And she's like, no. And I think the biggest concern is the stigma and all the things associated with that. And I know, again, I talked about uniformity, but the stigma, there's just so much stigma, and it sounds like, yeah, my dog would be doing it too. But
Yeah,
there's so much stigma and so much, just how, there has to be an alternative. Like I said, because right now, I mean, we know through the system not being funded now, a lot of the things that if they're funded in the county or in the community, it's a better outcome. And a 201, if someone can agree to the treatment, or they can do, they feel their own self-determination, and it's more if it helps the recovery versus feeling, because that it's forced upon them or mandated upon them because, they feel like a criminal, they feel like this is a punishment for them. And 201s, I know that they're not utilized all the time, but if someone can has their own self-determination, their outcomes are better. The better that they can recover, the better that they feel like they're going to ask for help. Because honestly, if people know they're going to be 302, they're not going to get help.
Sure.
And they will not go to the emergency department. I'm not saying it won't end all of the things that happen, Cody Balmer and other stuff may still happen. But I think if the more we can make it a recovery oriented system where you're treating holistically treating people and putting the funds to what they need to be done, and treating the whole person versus splitting and saying, here's behavioral health and the physical health world. I think the more we can do that, I think the better outcomes we'll have across the whole way. I just really get concerned because it is a violation. I mean, going into a mental health facility, it is a violation of your civil rights. It's like going to prison, and most people don't come back out better. But there has to be a better way to do it. And I just, I always say I'll work with you and I meet with you to do that stuff. And I'm looking now from a parent. There just has to be a better way to do it. And I just know that the system's broken. And I don't know if the Procedures Act is the way to fix it. I agree that you always do wonderful work. So I'm always supportive of you. And you know that. But it's I don't know. There's just so many other things right now with people not having food, people not having the social determinants they need, that making a change to Procedures Act right now, I think there's other lower hanging fruit that should probably be dealt with that maybe would be able to help in a way that people would have hope instead of just doing an involuntary commitment. But like duty to warn, maybe. I don't know. We'll talk later, but it's just, it bugs me. It bugs me on the civil rights and the what losing freedom part.
Sure, I got you completely. Yeah, it's not. I mean, as you just said, this is a 302 is last resort. It's never something that anybody wants to do. And the way that we have the system set up right now, I think is just not doing the job. So.
Well, I don't have anybody else in the hallway with me right now. I'm not sure if there are any other questions online. Now would be the time to raise your hand if there are.
Oh, it's Rosemary again. I'm sorry. I don't know if you know of Pat Deegan. Have you ever heard of Pat Deegan?
No.
Pat Deegan and Associates. She's a woman in recovery. She is talk about a mover and shaker. If you want to change people's perspectives, you should get her to come and have a conversation with them. She is in recovery. She's diagnosed with schizophrenia. She is a powerhouse. I'll put a link to her in the chat.
Sure.
She does training called Hearing Voices, where she puts you in the position of actually simulating that you're hearing voices. And never so much empathy ever do you leave with, right? To understand what it's like to live with that kind of distraction. And she asks you to do tasks and anything. But anyway, she is prolific in her not just her experience, but her ability to get people to understand the lived experience. And she is so well versed in what is and isn't right from the person's perspective in the system. I think she'd be of great service to you.
Great. I'm not familiar with the name, but obviously more than happy to talk.
Thank you.
I think that's a great suggestion, Rosemary. Yeah, Pat Deegan is, she's fundamental, I think, in thinking about recovery. So I put a link to her main website in the chat.
Great, thank you.
Yeah. So if there are no other questions, I'm going to thank Representative Mike Schlossberg for his time today. Rep Schlossberg, I hope you'll keep us posted on how things are going as things progress. As you can tell, you've lots of people in this room who are very passionate about this topic as per usual. So please stay in touch with us and we'll do the same. And thank you again so much. Good luck with the budget.
Thank you guys very much. I appreciate your time and your passion for this. I dropped my email in the chat. Please reach out if I can be helpful.
Thank you so much.
Thanks, folks.
So for folks online and in the room, just give us 1 second. We're going to be setting up to hear from our centers of excellence to get some updates from them.
In which the program works for this particular fellowship is that we partner with community employers, so community clinics who want to support fellowship training, experience in leadership, sharpening skills around recovery, around all the things that we've been talking about today, to stay tuned to what is important in the delivery of care and the hurdles and barriers and how to navigate that. So we partner with those employers and they commit to supporting that fellow in 4 hours weekly of dedicated time to the fellowship. And then we provide an infrastructure. They're generally at a site where they are experiencing community psychiatry work. And we partner with the rest of the 4 centers of excellence in our community psychiatry fellowships with educational opportunities and networking, these meetings that happen twice a year. I will highlight that in particular, we have the webinar series that occurs from September through June. It is hosted by the Center for Public Service Psychiatry. I hope I'm not stealing too much thunder, but we all participate in it and help deliver an hour twice a month of CME accredited excellent discussion and learning opportunities through a webinar that is videotaped and archived through the UPMC system. That occurs on the 1st and 3rd Thursdays from noon to 1 p.m. So those that would like to know more about it, please let us know because we love for you to join the excellent conversations that we have. Currently, I have a fellow who is a nurse practitioner at the UPMC clinic at Safe Harbor in Erie, Pennsylvania. They have a long name and I'm not going to get it right, but she is in her, she has opted and been supported by the Safe Harbor team to be in her second year of a fellowship. She has been in her first year looking at the role of cannabis. They generally, our fellows have a project that they work on, and so she has been looking at the role of cannabis in early onset psychosis and partnered with some really national folks that have been doing research out of the University of Maryland, I believe. This year, she is looking at how to broaden education that can occur easily within clinic settings. And so looking at how might we embed some dynamic educational opportunities within an EHR that any of the clinicians in a program might be able to access in their time and have availability as a library. So she's working on that project. And I'm in the recruitment mode. So for those that are listening online or in the room, if you have folks that you think might be interested, we cover really northwestern Pennsylvania. So we've had great partners with the UPMC Safe Harbor team, the Deerfield team, the Stairways team, and I'm sure I'm going to miss some from the historic past, and our federally qualified health center in Erie Community Health Net has also been partners. I think I will pause, and Val, who would be next? Okay, so Allison is my colleague. I'm going to turn it over to her.
Thank you, Marianne. Oh, I get to look at myself on the computer. I don't know if I can do that. So I'm Allison Swigert. I am the director of the community psychiatry curriculum locally here at Penn State, which is College of Medicine, which is in the Hershey-Harrisburg area. So we are the newest of the centers of excellence here in Pennsylvania, and originally started off with a postgraduate fellowship model, which for a variety of reasons didn't work very well in our location. And so in 2023, we shifted gears to a 4-year community psychiatry track, which is embedded within our general residency program, and have actually been able to partner with a local county and also with Capital Area Behavioral Health Collaborative for funding to actually add this community track resident as an additional resident that the residency trains each year. So we had our first resident start in July of 2023, who's currently a PGY3. We have another resident who is a PGY2, and then just welcomed 2 residents. We have 1 year of funding overlap. So just welcome 2 PGY1 residents this past July. And we are already on track for recruiting for psychiatry resident applications, which that whole cycle is open. We've already been interviewing for that for next academic year. So currently it's a separately matched 4-year track that offers trainees coming in with an established interest in public or community psychiatry with enhanced didactics, ongoing mentorship, and then immersive clinical experience in community psychiatry, particularly in the PGY 3 and 4 years. And we think, we're still kind of in the early stages of this project, but I think it does offer a nice opportunity to continue to kind of nurture many of the medical students who are coming out of medical school and going into psychiatry with an interest in working with underserved and marginalized populations, an interest in social justice and advocacy, and allows us to sort of keep that that little flame, the flicker alive during their first 2 years of residency when they're largely doing a lot of acute care. So, yeah, and I think the other thing just we're working on, and I would say is a challenge, is continuing to build relationships locally for good community psychiatry clinical opportunities. We've talked, workforce and access, I think, comes up in every one of our meetings, and that continues to be an issue. But it, and unfortunately also can be really challenging to find community psychiatrists who are quite busy and strapped for time, who have the sort of the capacity and the willingness to take on community psychiatry trainees. So that's something I'm trying to lean my energy into to make sure we can have those well established. All right, so I think I'm passing it on to Mark then.
Hi, everyone. I'm Mark Berger. I'm actually one of the associate directors of the Center for Public Service Psychiatry at UPMC in Pittsburgh. Normally, you would probably see Wes Sowers here, but he is on vacation, and so I'm taking his place. Our fellowship has been in place for 17 years and has matriculated over 60 community psychiatrists. I think our structure is very similar to what Marianne described. We have 4 hours of seminars weekly, and 4 times a year we have sort of field trips where we try to visit sites that people might not be exposed to during their regular residency training. The last few years we've had mostly PGY4s and PGY5s doing our fellowship. In the past, we've had postgraduate, sort of early career psychiatrists participate. And I think, a really exciting and interesting aspect of our fellowship right now is the introduction of remote fellows. So 3 years ago, we had somebody in this area participate. Last year, we had 2 fellows associated with the Harvard program in Boston, and somebody from the University of Washington in Seattle. This year we have 2 remote fellows, again, both in Boston, I think word of mouth, one at Brigham Young and one at Beth Israel. We also have 4 local fellows, 3 at UPMC and actually 1 at Allegheny Health Network. I think our projects last year were quite interesting. We had somebody do a project on environmental racism. We had one of our fellows work on a project to reduce the use of restraints in a county hospital in Seattle. And we had somebody who did some work with First People in Alaska, looking at the use of different interventions for alcohol use. So yeah, it's been a good year again. We've had lots of sort of initiatives. We have been working with the UPMC network to introduce our seminar series to that larger network and make it available. We've also made some more inroads in our residency training program, trying to sort of introduce people to the tenets of community psychiatry. And I think the earlier we get involved, the better. And so as part of that, we're trying to get an interest group going in the medical school, and really trying to kind of increase the footprint the center has within the School of Medicine at large and residency training. So, thanks.
Okay, so I know that Ashley Un is with us from University of Pennsylvania Online. Ashley, I'm going to ask you to wait just a second until we can switch over our audio. I'm going to go into the hallway again. So just give us 1 second, and I will chat when it is time to turn on your mic.
Hello, can you hear me? Hi, thanks for going out into the hallway to accommodate me. I'm Ashley Ann. I'm the program director for Penn's Community and Public Psychiatry Fellowship in Philadelphia. Our fellowship similarly aims to provide subspecialty post-residency training for early career psychiatrists interested in leadership careers in the public sector. We partner with 5 different community mental health affiliates for clinical placement, and also have administrative rotations with Community Behavioral Health, which is Philadelphia's Medicaid behavioral health carve-out, as well as the Department of Behavioral Health and Intellectual Disability Services. Our fellowship also has a weekly didactic series, supervision, mentorship, and protected scholarly time. And we currently have one fellow, Dr. Kelly Aka, who's attending today's conference virtually. She's also an APA Community Diversity Fellow and is doing her clinical placement at Horizon House, where she has initially been providing psychiatric care on their ACT team and assisting with some pretty challenging organizational restructuring of their ACT services, and is going to be transitioning to working on their Housing First team shortly, where she brings a lot of experience from her work in residency at Pathways to Housing. And she'll also be spending a little bit of time at Horizon House's Early Psychosis Peace Program. In addition to her clinical placement, she's also rotating with CBH and is involved in various meetings and projects related to clinical care management, quality improvement, leadership development, pharmacy initiatives, and is also doing a rotation at DBH-IDS, where she's providing consultation to the continuity of care team, and will be switching to working with the Behavioral Health and Justice Division after the new year. Penn Psychiatry has also been very lucky to recruit a new associate program director, Dr. Adobe Wabuo, who is attending today's conference in person. She is coming to us after completing her fellowship at Yale, and is also doing some work in our new CRC. Today's actually my first day back from parental leave, and she's been really keeping things running smoothly and jumped right in as we transitioned pretty much at the same time. So she has been covering as program director up until today. So I wanted to thank her very much for doing so. I'm looking forward to partnering with her going forward. We are also focused and actively recruiting for the 2026 and 2027 academic year. So if anyone attending today's conference in person or virtually is interested, please reach out to either of us. Thank you.
Ashley, thank you so much. Dr. Nawabu is out here in the hallway with me in case anybody had any questions. So thank you again. So are there any questions for any of our centers of excellence? Well, I will just say you're all doing an amazing job. We really appreciate your dedication to community psychiatry and educating the next generation of psychiatrists who are out there doing this work. It's really, really wonderful. And I know it's a harrowing time to be educating. So thank you again for all your hard work. I do want to say perhaps we can take a bit of a short break. We are surprising. Oh, well, I'm sorry. We have a comment from Dr. Ken Thompson. So I will pause there and let him ask his question.
Hi, everybody. Am I on here? I guess
Yes,
I
you
am.
are.
Okay. I just wanted to take this opportunity. We've been dealing with a lot of challenging and difficult subjects today that impede our progress in lots of different ways. But I wanted to ask the directors of the centers if you guys have any particular thing, and then I realize I'm putting you on the spot a little bit, any particular thing that you would aspire to have the center, your center, or the centers in general do. I think that one of the bromides against despair is to have some aspiration for a better future. So I'm just wondering if there's any kind of dream that you would like to to just say, just so we can keep track of it and maybe figure out a way to work towards it for the future relative to your work. And I'll see if there's somebody who, oh, look, Marianne has shown up. Okay, I'm going inside there.
So I appreciate that opportunity to think about hopefulness. And I realized that there were some things that I wished I had said, but they resonate with how we started this morning with Dr. Julie Graziani and Deputy Secretary Jen Smith, and thinking about how do we collaborate. And so the importance of how the fellowships collaborate with our communities and work across systems. So just as an FYI, all of our centers of excellence in Pennsylvania have a touch with community psychiatry fellowships across the nation. And some of that is organized, or maybe much of it is organized through the American Association for Community Psychiatrists. And they are a nice supporting partner with the webinar series that we have. I think that for me, in our community psychiatry rural program, I am looking at how do we partner with regional residency programs as part of electives in the 4th year. So if you can't do something that is a full thing, how do we build? And it is possible, certainly in the program that I am running, and we've had some wonderful folks come through that elective process, and then go on to work in community psychiatry programs, as well as doing a full fellowship in that process, and then come to work in places where there is a strong need. So I think part of what I want to send is a message of how do we continue that expanding concentric circles of collaboration and coordination with this effort, because it's a really important one as we look at how to support access to care for families and patients in our community who are in need of help. How do we work in collaborative care models? These are all important themes for access to care into the future, and being responsible for our fiscal component. So some thoughts, and I see Ashley is, Allison is lined up after me, so I'm going to step aside from here and let her take the chair.
All right, well, we're all giggling about being in the hallway and going in and out the door, but it just occurred to me that this flexibility and adaptability is really one of the core tenets of community mental health care. So kudos to all of us who are rolling with it, especially Val here. So couple thoughts I have. First is in terms of hopefulness. So I myself am very involved in residency recruitment at Penn State. And I have medical students and residents rotate with me in clinic, and I'm involved in their education. And I think one really hopeful thing is just how much perspective these young people have about the world, its injustices, how politics and structures and law influence physical and mental health. How, as I mentioned earlier, how oriented a lot of these young people are towards social justice and passionate about it, and looking for opportunities to do advocacy for mental health, even in medical school. So I think it's just so impressive that they're coming out of medical school and into residency with their eyes wide open about all of the non-biological factors that intersect and create the conditions in which mental illness can develop. And so, our goal is in residency and in fellowship is maybe not so much to have to teach them that to them anew, but be able to nurture it and develop it in some way. To think through what my second one was. Maybe it'll come back to me. I think in terms of what I would hope for, one thing that I have hoped for is a way to support our early career community psychiatrists after they've finished training programs. I myself have kept in touch with several graduating residents from our Penn State program, and have just really helped to support them through some very big challenges that they faced going out and being a fully practicing psychiatrist. I just was contacted by a Penn State resident grad from a couple years ago who emailed me last week and asked, is it normal to feel less certain of my decision making, sort of the further out from residency I go? And I emailed back and enthusiastically said, yes, I think that is totally normal. So I'm interested in ways that we can, I guess, continue to foster community and support even after psychiatrists leave our training programs.
Perfect. All right. Dr. Nawabu, do you have anything to add?
Hi, this is Adoe. I think I share a lot of the optimisms, just the interest that we still have in community psychiatry, the fact that there are still these fellowships that exist, even though we're actively, trying to recruit, but the fact that there are, even this opportunity, the fact that we're still sort of chugging along, gives me a lot of hope. I'm, just started. I've spent the last basically just knowing where the bathrooms are at work for me has been great. But one of my hopes is, of course, expanding the fellowship, sort of exposing younger and younger trainees. So we're gonna hopefully start with the PG4s, and maybe even before that over at Penn is the hope for a couple academic years in the future. Yeah, and then I love the fact that we have the COE meetings and we're able to collaborate as sort of the program leaders, but I'm hoping that we have more and more opportunities for the fellows in the different fellowships to interact and do work across the state. I think that would be really great since we have such great collaboration. So yeah, those are my hopes and dreams. But yeah, so far my biggest dream has been to, find all the bathrooms, which I've done. So right now I'm thriving. Happy to be here.
We're very happy you're here. And then last but certainly not least, Mark has joined us, so he will continue the hopefulness.
Yeah. No, I think I have to echo what Allison was saying, which is that I see a lot of enthusiasm and dedication towards social justice in our fellows, our residents, and I think the same is true for like the medical students that have shadowed me in my full-time job as an ACT psychiatrist. I think one of the things that I would love to see happen is in community psychiatry, we tend to work in teams, and I wish we could do more training as teams. Sort of an interdisciplinary cross-fertilization. I think therapists, social workers, peer specialists, have a different angle on what I would call patient care, the people we serve, and that is, not necessarily well represented. In the past, our fellowship did have quite a number of involved peers, and we would like to see that happen again, including families. So that is something that we have to revive. Some people just walked by in the hallway. Sorry about that. So yeah, I look forward to contributing as a fellowship to the creation of a better community psychiatry community, and something that serves all.
Thank you, Mark, and thank you everyone for your additional insights. We are actually going to, thought we were going to take a break, but I'm thinking perhaps we can just go straight into the next portion of our programming. Jill, are you on? Oh, good. Hi.
I am. Can you hear me okay?
Yeah. So, Jill, thank you so much for being here. I just wanted to quickly introduce you. Jill Stimple is here to speak with us about the OMHSAS 302 Bulletin. So we really appreciate you being here today, and I'll let you take it away from here. Thank you.
Great. Thanks for having me today. I apologize I cannot be in person with you all. Since Dr. Adair's retirement, I have become the token Pittsburgher on the OMHSAS executive team. And with the budget not passed, we have some restrictions on travel. So I would have loved to have been in the room with you all today, but I'm glad I could still join remotely. So for those of you who have not had a chance to meet me, my name is Jill Stemple. I serve as the Bureau Director for Policy Planning and Program Development at OMHSAS. I have been in and around OMHSAS for about 10 years now. I started there in 2015 working on community mental health services block grant funding, and served in several roles and came to this role about 1.5 years ago. Personally, I like folks to know I'm coming at this from an experience of lived experience with severe mental illness. I spent about half of my life struggling with really severe suicidal depression in and out of hospitals. I learned what a 302 was when I was 15 and was 302'd. So this is an issue I take really seriously, I believe is incredibly important. And I really appreciated what Rep. Schlossberg said about how delicate a balance it is that we have to strike with our 302 policy in making sure that folks who need treatment and get good and timely treatment, and that we're also not trampling on folks' civil liberties. So I appreciate all of you and your input into that work. As we at OMHSAS continue to try to strike that balance with the Mental Health Procedures Act we have today, we appreciate your feedback on that as well. So for folks who may not have been aware, OMHSAS issued an updated 302 forms bulletin in the spring. That was a project that I inherited from my predecessor, and I will take full accountability. This process has been a learning opportunity for us. So we were really pleased that folks reached out very quickly to us and told us that there were concerns, there was issues, there were things we needed to think about a little bit further. And we really do want that to be the relationship with our stakeholders, that we are collaborative, we're hearing from all of you, and we're coming up with the best policy that really works for the system. So thank you for those of you who did reach out and help us make that decision that we needed to put that bulletin on pause to think about some of those issues and revisit. My team has been working on that for the last couple months. We did receive 87 comments back on that first bulletin and the forms attached to it. We have been working on updating some of those forms, and I'm going to talk a little bit about what that looks like and where we're going to go from here. And where we have been holding it a little bit, because we've been so grateful to have Julie Graziani join us, who you got to hear from this morning, and get her input on it, having that clinical voice back in OMHSAS after a little bit of a break there with Dr. Adair's retirement. So first I'm going to talk process of how we're going to move forward, and then I'll talk about some of the substantive things we're looking to change. So process-wise, what we are planning to do is issue a new bulletin. The language in the bulletin itself is going to be pretty substantially the same as it was in the last bulletin, other than adding some language explaining that we're updating some of the forms based on comments. That bulletin, when it is issued, will have a separate effective date from the date it is published. We know that was a big concern for folks the first time around. Generally speaking, our bulletins are effective on date of publication unless we put that separate effective date in, and we recognize that did not give folks enough time to plan, to do training in your system, to get EHRs updated, etc. So we will have that time built in this time around to make sure that you all have time to adjust to the new forms. We will also make sure that there is a training and technical assistance session available and held prior to that effective date, so that not only do you have that time to work in your systems, but you have the time to hear from us what those changes mean, ask us questions, etc., before it goes into effect, and lots of time to adjust. The other thing that Deputy Secretary Smith mentioned this morning that we're going to be doing differently this time around is, rather than going straight to publication of the new version, we're going to do a brief advanced review process. Bulletins don't have a structured public comment period in the way that our regulatory work does, but we recognize that there is an opportunity for us to get that feedback on bulletins, particularly when it's a bulletin where we're making a policy choice. It's not so much that we're being dictated by, a federal change in statute, where we should take the opportunity to hear from our really core stakeholders, our county partners, the practitioners who are doing the work, to get that feedback and make sure we're hitting the mark right. And if there's concerns, address them before we publish the bulletin in the future. So we will have that advanced review session coming up in the pretty near future. I am very, very close to dotting the last I's on that and making some changes that Julie had recommended to us. So hopefully that will be out here in the next week or so, as long as some of our competing priorities let me get to that. But we will be sending that out through the counties. I'm also happy to share it with the Psychiatric Association if that's helpful. It is not a broad public comment, so we will not just be putting it out for everyone in the world to look at. We're not permitted to do that, but we can send it out to some narrow groups, and you can certainly be a part of that groups that see that. So that's the process issue of how we're going to move forward with the new bulletin. Some of the changes I wanted to walk through that we're looking at, and then I wanted to leave a lot of time to open up to questions, comments, concerns from you all, and an opportunity to hear what you're thinking. So the big changes are all going to be on the Mental Health 783 or the 302 form, as it's generally referred to in the counties. So we're looking at adding back some fields that were taken off. We will be putting back on the county program line on the headers, and that was really a request from our county partners. For you all, I think most interest, we're going to standardize language across that form. Currently, we use examination and evaluation a little bit interchangeably. We're going to standardize that to make them all examinations to make sure it's clear what we're talking about and that those are not two different things. We're going to remove some of the language around imminency that doesn't have support in the current Mental Health Procedures Act. We are removing some check boxes that folks did not like around unknown factors for when we're talking about a question that's premised on what someone's personal knowledge is. We are returning the check boxes that were very much in demand on the form, rather than making you circle a letter or have it sort of be ambiguous. Those check boxes are coming back. And then on the physician exam form in particular, we are adding a section that will allow folks to address the timing of the 302 signature when it is not an individual newly arriving at the facility, but someone that has already been there in treatment, potentially as a 201, that is now needing to convert to a 302 because perhaps they've given that 72-hour notice, they want to leave. The doctor does not think that is medically appropriate, and you're initiating a 302. We recognize that those forms made it a little tricky to document that situation rather than an initial showing up in the emergency department 302. So we will be adding some fields there to help with that issue. The other major change we will be making is we will be adding the MH781 BCD form to the list of forms in the bulletin. For anyone who is not familiar with that form, that is the voluntary commitment rights form, and it was not listed in the current bulletin that is out. By listing that newly, we will have an opportunity to update a little bit of the language in there that's outdated, and get that translated into the 5 languages that we're translating all these forms into for the field. So we're excited about that opportunity as well to make that available in multiple languages for the folks you're serving. Really, our overarching goal here is to try to strike that balance between the reality on the ground that our counties are different and we have a county-run mental health system, but we are a statewide mental health system that needs to refer folks across county lines, not infrequently. We were already hearing those concerns at OMHSAS around, you know, who's counting the 2 hours when and who's doing what forms in which way. Right now in the current system, and particularly as we push towards our new transformed mental health crisis system, and we're really looking at regionalizing our crisis system in some ways, particularly for the emergency behavioral health walk-in centers, where those standards are being raised very substantially above the 1993 standards we've been operating under. We really think that need for some more consistency is going to continue to grow. Just one of our emergency behavioral health walk-in centers that has already opened and operating under the new guidelines in Dauphin County has served, I believe, folks from over 20 to 25 counties. If you think about that from an administrative perspective, if one provider needs to deal with 25 different versions of these forms to process people through their walk-in center, that just becomes an administrative nightmare. So it is important that we move towards making these a little bit more standardized across the state, so that folks in crisis are not sitting there waiting for various administrators to fight out which form is filled out and is it the right version. And no, you don't have my check boxes. We really need that to be a statewide form. That means that people can get treatment and they're not waiting on paperwork when they're in a behavioral health crisis. So those are my high levels that I wanted to make sure I shared with you all today. But like I said, I really wanted to leave lots of time for you all to ask me questions, comments, whatever is helpful to you all to talk about how we move forward with the Mental Health Procedures Act. I will say, I know Deb had asked a little bit ago when Rep. Schlossberg was on about training. We do have some training planned for our My OMHSAS system around the Mental Health Procedures Act. We have it in a little bit of a holding pattern. We were a little concerned about investing in developing that training now if that bill to overhaul the Mental Health Procedures Act is going to move forward in the near future. So we're kind of continuing to weigh what's the right time to move forward with that. But we are committed to having a Mental Health Procedures Act training available on My OMHSAS, both for crisis workers specifically, as a part of our crisis certificate, and then potentially if there's a need, a larger training. We're also happy to talk about that and hosting that on the My OMHSAS website to help promote consistency across the state. So now I really am going to stop talking, and I'm excited to hear what comments, questions, concerns, things you want to make sure OMHSAS is aware of.
Jill, thank you so much for that update. Really appreciate it. I'm going to wait to see if anybody joins me in the hallway for questions. In the meantime, if folks have questions online, now would be a good time to raise your hand. But I would like to say, Jill, I think that's great to hear that you're willing to share the draft. You can certainly send that to myself or Lucy, whomever you've been communicating with. I think there are many people who would have a lot of interest in making sure that they were able to weigh in on that. So thank you so much for that offer. So for folks who are here live, I know several of you had questions. Perhaps your questions were answered by Jill's presentation, but I want to make sure that you have the opportunity to ask any clarified questions. If you'd like to join me in the hallway. Oh, we have some takers. Oh, we have some takers. Okay, Marianne.
Hello, Jill. Marianne Alba here from Erie, Pennsylvania. And I appreciate the final comments that you had around the potential opportunities for training. And I'm not certain around the timeline of changes to the act and what that legislation might look like. And so I would put in a pitch to perhaps look at, as things get finalized with forms, to put together some training. And I know within our county system, we've done that, and we've done that actually yearly for some of our residents who are entering our system in Pennsylvania and in our Erie County, to be familiar with the procedures and process and what the act looks like. And so I think really there might be, I determined that there is potentially an interest for training
sooner rather than later, that I wouldn't necessarily hold off. And if we can get that kind of infrastructure into place, then if and when that legislation comes through, you'd have that structure. So it would be an easy, we adjust for the new rules and expectations and have that system in place for training. So just a pitch for that. Thank you so much.
Yeah, thank you so much for that. So to clarify, yes, we will have the training and technical assistance session on the forms when they come out. We will not hold that for Rep. Schlossberg's work. So we will definitely do that piece of it. I think what we're sort of working on the timing for is more, do we do a robust Mental Health Procedures Act 101 sort of training to get, you know, more of that overview up to speed, or do we wait until there's a bill? So we'll keep working on that, but I think certainly we will do the forms as soon as those forms are ready to go out for publication. So
thanks so much.
All right. We have another question.
Yeah. Hi, Joe Lloyd Wirtz here. Thank you for being with us today. I appreciate it. Having been part of a number of trainings over the past 15 or so years on this topic across the Commonwealth, the primary issue that I've seen with those trainings is they don't require the attendance by the people who matter in the implementation of the commitments. They don't routinely, almost never include the county judge that's supervising that process. And they often don't include the mental health review officer, nor the delegates who work under the mental health administrator as well. I don't know if you have thoughts and ways to get those folks involved, but without their involvement, you're going to have difficulty attaining consistency across the Commonwealth and the 67 counties who are responsible to enforce it. Just an observation, but thanks.
thanks, Lloyd. I think that's a really important thing to remember. I think we get really focused on OMHSAS at the mental health side of it, the treatment providers, and aren't always as cognizant about the court side of it. I will say we have developed a really strong relationship with AOPC over the last year, as they have been working as the Judges Association to be more involved in the mental health system and be better partners. So I think there's a real opportunity for us there, and I appreciate that reminder. I will take that as a note that we make sure we coordinate with them to make sure that information about the training gets to the judges and the mental health review officers. And we can certainly make sure when we're communicating with the county mental health administrators that we'd encourage them to include their delegates in those conversations. So thank you for that, Lloyd.
Okay. So I'm not seeing anybody else here in the hallway. I just want to make sure there's nobody else who has a question. So I think that answers all the questions for those in the room. Is there anybody else online who has questions? All right, I'm not seeing any questions online either. Jill, thank you so much for this update. This has been very helpful. Please keep us posted on what we can do to assist in this process, and we really do appreciate your time to update us on this today.
Thanks for having me today.
Thank you. Oh, no, okay, never mind. Okay, great, thanks, Jill. All right, so we are ahead of schedule, which almost never happens, but that's a very exciting thing. So I think we're gonna have closing remarks. If everybody could just give us 1 second, we're just gonna need to switch the audio so that we can go back to the in-person room. So just 1 moment.
Okay, I'm back from the hallway. So I feel like today was a really good. Oh. Can you just close my hole? Did that fix it? Oh, that's a good question. All right. Did it work? Okay. Are we good? No echo? Oh man, we did it. Even with a few technical difficulties. All right. Good job, AV. We figured it out. So a lot of great information today. Thank you so much for your time. I just wanted to take a few moments to thank the team. So Lucy Ann Green, thank you so much. Deb Shoemaker, thank you so much. And Katie Morton, our trusty online moderator, thank you so much. As Ken said this morning, Thursday nights via Zoom, we meet 6 to 7 to talk about various topics. So if you'd like to connect with us there, we're talking about many of the things that we talked about today. Also, please keep posted with emails that are going out. We are actively working on how we can address some of the Medicaid and SNAP issues that are coming up in the Commonwealth. So stick with us and stay in the loop. Hopefully there'll be some solution-focused actions that we can be collectively working on together. And I just wanted to thank you all for your attendance today. I know this is a very challenging time, but it gives me a lot of hope and encouragement to see us all here together, working together, learning together, and hoping for a better future together. So thank you so much, and I hope you have a safe trip. Oh, Lloyd. You do? Do you want me to come to you? Okay.
You miss somebody you ought to thank. We ought to thank. And that is you. Thank you very, very, very much, Val. Good work, good stuff. What are you going to do when you get home? You got to advocate. That's what we're about.
Well, thank you. That's very kind. Thanks. And as Lloyd said, don't forget to advocate. And tomorrow is a very important day. So don't forget to vote. All right. Well, thanks, guys, for everything. See you next time.
Thanks a million. That's great.